Break the rules on the last day. So declare the meeting open to the public. Just to advise members, committee meeting is now recorded and will be broadcast throughout Parliament buildings and online. Just to advise the members in the public gallery, you are more than welcome to use mobile devices so long as they're in airplane mode and must all be muted. You can connect to the Wi-Fi. The details, passwords are there in the gallery rules. And it's not permitted to take photographs or record any of the meeting. So item 1 is apologies, and I have received none. A couple of members just will be late, but no apologies for the meeting. Are members aware of any apologies? None? Okay. So Chair's business. Just to let you know, obviously this is the last committee meeting in advance of summer recess, so it's standard practice to delegate authority to the Chair and Deputy Chair during periods of recess to submit views on the releasing or withholding of information in any non-routine or contentious freedom of information requests received by the committee. Any such views expressed would be brought to the attention of the committee at the first meeting after summer recess. So are members content to delegate authority to myself and the Deputy Chair to submit views on the releasing or withholding of any information in any non-routine or contentious freedom of information requests received over the summer? Happy? Okay. Second issue then, I received a letter during the week from the SOAS group in Fermanagh in relation to the department briefing last week on the South West Acute Hospital, just looking for the briefing. So I mean, I didn't want to send on that information without getting the committee's agreement. So are members content that we can send on that departmental briefing to the members of that group? Okay, and then obviously there's been some developments this week with regard to the South West Acute, and obviously Alan has previously mentioned the Causeway Hospital and Antrim Hospital issue in the Northern Trust area, and both those are with the Minister in terms of potential changes to surgery in those hospitals. So I'm kind of hoping and suggesting that potentially we contact the Minister just to make sure that any announcements in relation to either of those are made when this Assembly is up and running, as opposed to over the summer, so that members have an opportunity, should there be any issue, to question that, and also to again put on record that any decision needs to be in the best interest of patient outcomes.
He had indicated, Chair, that he expected a likely announcement at a point in time in June. Now, obviously that hasn't happened, and we're now into summer recess as of this evening. So I think it is important that whatever announcement is not done on a Friday at 5 o'clock, that it is done during the period of time in which this House sits. So I agree, 100%.
Okay, moving on then, members. The other thing, just before moving on, the committee will consider an end of session report in September, as agreed by the chairperson's liaison group on June 24, so that'll come back to us when we're back. So moving on now, draft minutes. Draft minutes of the meeting held on 26th of June 2025 are page 7. Are members content to agree them? Okay, thank you. Matters arising? None? Okay, so moving on now to item number 5, which is an oral briefing on the Youth Assembly. So can I refer members to the following papers in our pack at tab 5. One is a note on the Minister's briefing to the Youth Assembly, and that's at page 20. And also a Youth Assembly report on mental health in schools at page 22. So can I welcome from the Youth Assembly Brooke Ewing, Christine Farry, Donald Mullen. I just check my eyesight. Yep, Donald's there.
I'll shut up.
Finn McCoy.
Yep.
Very welcome. And Daniel Gracie. So you are all very, very welcome before us today. So what I'm going to do is invite yourselves if you want to make some open remarks, and then we can take some questions from members. So over to yourselves.
Good afternoon. My name is Donald. Thank you for meeting with us today. Over the past year and a half, we've been working hard to understand what matters most to young people, and today we want to share both what we've learned and what needs to change to improve mental health in schools. We understand that this falls under the Department for Education, perhaps more than the Department for Health. We have shared the reports and recommendations with the Education Minister and look forward to meeting with him in the future. We presented to the Minister of Health last Friday. He supported our recommendations and made a commitment to follow up with the Education Minister. Now, some background on our work. The Youth Assembly has 3 committees: Education, Health and Rights and Equality, formed based on responses to our big youth survey launched in January 2024. Nearly 1,800 young people aged 11 to 21 from across Northern Ireland shared what matters to them. In May 2024, we held a planning day and chose to focus on mental health in schools. The stigma remains strong and support varies widely between schools. We want to understand why and how it can be made better for everyone. We began our research by reviewing key frameworks and services relating to mental health in schools led by the Departments for Health and Education. In November 2024, we met with the Chief Inspector of the Education and Training Inspectorate, ETA, and her senior officials. During the Q&A, they emphasised how poor mental health affects learning outcomes and underlines the need for consistent emotional well-being support in schools. We met with the Minister of Health in January 2025. We welcomed his acknowledgements of the growing demand for support and the challenges many young people face in accessing timely care, and appreciated his commitments to explore further strategies with health and education partners. The discussion highlighted the urgent need for accessible, consistent mental health support to help every child and young person thrive.
My name is Daniel. I'd like to tell you about our Youth Stakeholder Day, which we hosted in March 2025, as we wanted young people to share their experiences with mental health, especially in schools. The day included workshops designed to deepen our understanding. 47 young people aged 12 to 18 attended from across Northern Ireland, representing the Northern Ireland Youth Assembly, Nikki, Angel Eyes, Belfast YMCA, Start 360 and members of the UK Youth Parliament and the Children's Law Centre. Our first activity asked participants in small groups to rank potential causes of ill mental health. Each group received an envelope with potential causes to rank from most to least significant, and they could add their own. Each group chose a different top issue, showing the variety of challenges young people face. These were isolation and loneliness, family circumstances, bullying, mobile phones and social media, childhood trauma, school pressure, and poverty. Additional issues frequently mentioned included gender and sexuality, exam stress, stigma, and identity struggles. These responses highlight how complex and interconnected mental health challenges are for young people. Next, we asked participants about their awareness of existing mental health reports and school-based programs. Each resource was briefly explained, and participants indicated whether they have heard of it or not. These results were striking. Most had never heard of many key supports, including practical services like text nurse or emotional wellbeing teams in schools. This shows a major gap, not just in services, but in communication and accessibility. Though they were designed as icebreakers, these two activities gave deep insights. Young people understand the pressures they face and are asking for visible, accessible support. If we want real change, we must keep listening and ensure the systems we build genuinely serve them.
My name is Finn. In our first workshop, participants responded to statements about mental health stigma using coloured dots to show agreement or disagreement. The results revealed several key insights. Stigma is real. Most agreed that mental health stigma remains strong, especially for young people. Social media. Divided opinion. Some saw it as harmful, such as trolling. Others saw it as supportive and empowering. Talking to peers. While some felt safe discussing mental health, others still struggled. Safe spaces. Most agreed these are lacking in schools. One suggestion was to create a well-being hub. Peer judgment. Bullying and fear of being judged for seeing a counsellor were common concerns. In school conversations, few felt comfortable discussing mental health in school. One student noted their math teacher doubled as their personal development teacher, raising questions about staff training. Awareness matters. Many felt stigma is fueled by a lack of education and conversation. Teacher roles. Views were mixed on whether teachers take mental health seriously or see it as their responsibility. Trust in counselling. Several felt uneasy accessing counselling at school, citing unfamiliar staff, privacy concerns and a lack of trust. In summary, young people want to talk about mental health, but stigma, especially in schools, remains a serious barrier. They need safe spaces, trusted adults and real understanding. Workshop 2 was about mental health provision in schools. Using a real-time quiz, we gathered young people's views on school-based mental health support. Here's what emerged. Most knew a counsellor was available, but opinions on the quality of the service were mixed or unclear. Waiting lists. Many said they were too long, others didn't know, showing communication gaps. Access during class. Over half said it was hard to leave class for support. Safe spaces. Few said their school had one. Additional supports. Varied. Some had pastoral care, Senkos, youth workers or drop-ins. Others had nothing. Staff training. Fewer than half believed their teachers were trained in emotional well-being. School-wide strategies. Most weren't aware of any mental health framework in place. External signposting. Positively, most said schools refer students to outside support services. Self-referral. Only about 20 young people knew how to self-refer for counselling. Peer-led support. Awareness was mixed. Some had initiatives, others didn't or weren't sure. Workshops. Some had attended mental health sessions, but these didn't always seem part of a wider strategy. Most concerning. Nearly half felt their school does not take mental health seriously. In summary, support exists, but it's inconsistent, poorly communicated and not always accessible. Young people want flexible counselling, trained staff, safe spaces, clear information and school cultures that prioritise well-being.
My name is Christine. In the final workshop, participants designed their ideal mentally healthy school. Their ideas reflected 4 major themes. 1. Environment. Calm, welcoming spaces like wellbeing hubs, quiet gardens and zen dens. Less rigid schedules, more outdoor time and freedom for self-expression, such as relaxed uniform rules. They imagined a welcome school and community hub where connection mattered as much as curriculum. 2. People and support. Support went beyond slogans. Trained, compassionate teachers, on-site therapists and nurses, peer support groups and wellbeing ambassadors, discreet self-referral counselling tailored for neurodiverse students. As one group put it, more than a poster. 3. Curriculum and culture. Mental health education should be mandatory and ongoing, not just occasional workshops. Suggestions included weekly wellbeing classes, creative outlets such as art, drama and music, less pressure from standardised testing, and a shift in focus from grades to people. 4. A holistic approach. They called for healthier food, better sports facilities, modern spaces, and collaboration with external organisations. In summary, these young people didn't just dream. They created a realistic, powerful vision for change. Their message is clear. Schools must support mental health with intention, investment and care, just like with academic success.
My name is Brooke. After reviewing research and consulting experts and young people, the Northern Ireland Youth Assembly Health Committee wishes to make the following recommendations. Introduce stigma reduction programmes in personal development classes supported by outside organisations. Provide designated indoor and outdoor spaces like quiet rooms or zen gardens for students to talk and relax. Prioritise effective counselling with shorter waitlists, self-referrals and easier access during school hours. Invest in better training and support for learning for life and work teachers and pastoral staff, including professional supervision. make mental health a compulsory, statutory subject taught annually from primary school onwards, encourage whole school mental health activities involving the community beyond posters such as sports, mindfulness, arts and healthy eating, establish pupil peer support groups with training and ongoing support, maintain ongoing youth voice in schools and government on mental health issues, and ensure strong collaboration between the Departments of Health and Education to provide appropriate services for young people. To finish, we'd like you to hear from some of the young people who attended our Mental Health Stakeholder Day in this short video. Today we're here in Stormont Parliament Buildings doing a mental health stakeholder event.
We have different youth groups here telling us more about what different people think about mental health in schools and their opinions.
Our health committee finds that mental health in schools is an important issue to address because it was one of the biggest responses on our big youth survey.
Because school for young people is such a big part of their lives that they're there for most of the week, and it should be a space that's like safe for them to talk about how they're feeling.
I feel like it's beneficial so people can understand other people's problems, why they have mental health.
I think it's important to approach the conversation because there's such a stigma around mental health. If it was discussed further in schools, I feel like it would be easier to talk about in general.
This is a time where young people are struggling and suicide rates, particularly in teenagers, are skyrocketing. So I think there should be, necessary supports in school that are easily accessible to all students.
Especially in secondary school, there's so much pressure on you, and it's a time where a lot of people can really struggle with their mental health and not know where to turn, and obviously they're in school every day, so it's a great place to be educated and get advice about it.
Myself and a lot of people I know have had serious impact on their education from their own mental health problems, and I think that focusing on it in your education, it's always going to affect all parts of your life, but specifically your schoolwork, and especially teenagers going through GCSEs and A-levels. I really struggled with my mental health through my GCSEs, and there wasn't a lot of support available. There was support available for my mental health problems, but not alongside with my education. So I think it's really important to focus on how it affects your education and how you can still get an education while struggling.
In my school we have a hub for people to go to, but that's mainly just to catch up on work, and it's not really private. We don't have a counsellor. If you really want to go speak to someone, you have to go and speak to your form teacher, who some people don't want to speak to because they don't feel comfortable.
In my school, I don't know if this is like it in other schools, there's more focus put on exams and getting good marks rather than it is on mental health. So I feel like there needs to be more focus and more resources and more widely talked about.
It's awkward for people to talk about it in schools because they feel like they might get ridiculed or not understood for the problems they have. In my school, I find that the approach to mental health is often quite tokenistic, and that young people are given the resources to adequately deal with the mental health problems they may have.
I think it's all posters. There's nothing that's actually interactive.
In every school there should be a room where people can go,
or a quiet room where you can just sit. Rooms for people to go and speak to people, or for people to go and calm down in whenever they are getting upset or they feel anxious.
But I think it is important that we reflect more on mental health and how it can impact people's grades, because that's all people seem to think about whenever they think of school, but it's hard to achieve that with the way that things are in Northern Ireland at the minute.
I think investing in youth right now and their mental health is so important, because if you invest in youth now, you have less problems in the future.
There should just be more awareness and training for teachers so that they know how to deal with any issues that people are having.
It should be made less complicated. You shouldn't have to go to a teacher to get referred to a counsellor. You should be able to go directly to a counsellor. You shouldn't have to speak to a teacher if you don't want to.
The big thing we need right now is more funding to support young people with the mental health problems that they have, because the lack of funding for mental health problems for young people in comparison to even mental health funding for adults is stark.
And outreach programs in schools is a very good way to ensure that our youth are supported and have that outlet of support that they might not get at home. because I think that's the case for a lot of our young people.
We need to make it a normal conversation. We need to make it something that everybody can talk about in a casual setting, and make it something that people aren't afraid to advocate for, and make it something that we can just go into a room and talk about our feelings instead of so much stigma being around it.
Seems to be a very cookie cutter approach. Now, it's not that what works for one child or what you've implemented in one school will work for everyone. It needs to be better considered. It needs to be revamped completely, and even the application of it in the likes of special needs schools, it needs to be more suited to the children and their needs, rather than this worked in this school, so we're going to apply it right across the country.
I think it's incredibly important to talk about mental health in schools, as it is an issue that affects the majority of the students nowadays.
I really enjoyed the event. It was very nice talking to people from all these different organisations about mental health in schools.
Finally, thank you for listening. We'd like to ask the committee, how will you support our recommendations and what would you advise as our next steps?
Okay, well, first of all, can I thank all of you for giving very clear evidence to the committee and for all the great work that the whole Youth Assembly have done on the very important topic of mental health. Your report and recommendations the report is very thorough, and the recommendations are eminently sensible. So you've asked us a couple of questions in terms of help. Obviously, a lot of the issues are maybe more so for the Department of Education rather than the Department of Health, but you have met with the Health Minister. Can I ask, how did he receive these recommendations, and did he give a commitment to engage with the Minister for Education to try and take some of them forward?
Yeah, unfortunately we couldn't meet with the Education Minister. We did ask him to, and Rights and Equality Committee, who published a report into young women's rights in schools, and the Education Committee, who looked into LLW in schools. But we are very grateful for Mike Nesbitt for taking the time out to speak with us. He was very welcome of the report, and he said he would share it with executive colleagues, so he's definitely very supportive.
Okay, that's good to hear. Maybe in terms of us, then you ask us what we could do to help. Maybe we could write to the Minister of Education and ask that he would engage with you on the recommendations that you have made. Would you like us to do that?
That would be great.
Please, thank you.
Okay. Dan, you want to ask a question?
I do. One of the issues that's very, very prevalent in school, and it's the issue of bullying and mental health. And I was recently speaking to a group of sixth formers, actually, in a local grammar school, and they were asked how many of them had ever experienced bullying, with Snapchat, WhatsApp groups, that kind of thing. And about 2/3 of them in the room, there's about almost 40 young people there, and about 2/3 of them put up their hand to say that they'd experienced bullying. Now, I'm very old, so when I went to school in the bus. I lived on a farm, went to school in the bus. If I wanted to contact any of my friends, I had to go and ask my mum and dad, could I use the phone in the hall where they could hear everything that I was saying. So I accept entirely that life has changed and you're constantly on your phone. Have you considered the impact of phones on bullying and mental health?
Yes, we have. I think we said it in our report and in the video. We were talking, and when talking about what are the big main issues that impact people's mental health, we did talk about how mobile phones and the use of social media is a big impact, whether it be things people say to you directly or just things that are posted or things you come across online. We do understand that's a big impact on your mental health.
Yeah, no, definitely.
You got thrown under the bus there.
No, I think social media is everything. Young people are on social media, yes. And I think that's probably going to be the case for a long time. But I think it's something that really needs to be looked at about social media guidelines. There is guidelines always in place, but I think the question is, are they strong enough? And I'd say a lot of young people would say they aren't strong enough in protecting young people.
Excellent. Thank you very much. I think that is a very big issue. Mm-hmm. I do think that's a very big issue.
Orlia?
Yes, so thanks very much for your presentation and for the wonderful video that you presented there. I think that
You have articulated all of the issues facing young people in our schools extremely well, and no better people to hear it from than the young people themselves. So we really appreciate all that feedback, because it's very useful for us. So just in terms of it come up from a couple of the speakers and up in the video as well, just around the awareness and the training for the teaching staff and your teachers. And I think as it mentioned, fewer than half of the people that responded to your consultations have believed that your teachers were trained in any sort of mental well-being. And then I think it was one of the young men on the video as well mentioned around the suicide rates, that you all know is obviously an ongoing issue, sadly in our society, not specific to us, I mean, it's global. But so just locally then, what I was thinking was, I would like to get your feedback in a consultation that's actually went live a couple of weeks ago around hopefully creating a law here locally that will mean that there'll be a statutory duty, so there'll be a legal responsibility on all departments to provide suicide prevention training to all frontline staff, so government employed frontline staff, which would obviously then include all of our teaching community. So there's a Survey Monkey consultation out at the moment on that, and I'd be happy to pass the details on to your team after today's meeting, because I would just really love to get your feedback on what you think about that, and if it's a good idea or if it's not. But just conscious that we know that over 70% of people who sadly die by suicide actually aren't involved in any mental health services. So you just wonder if the mental health problems was being picked up sooner or quicker, particularly in your schools, because your teachers probably spent more time with you than your parents or your siblings do, because you spent most of your hours, sadly, in school. So, so I just want to throw that back to your group, and maybe it would be something that you could give me a wee bit of feedback on to see if you think it's a good idea. But I really value your opinions and the work that you have put in, so thank you very much. And just to say as well, the issue around that stigma, that horrible thing that is called stigma, it's a terrible thing, and that's the blockage to most people asking for help, seeking out help, talking about their problems. It's just that thing around stigma, when the reality is we all suffer poor mental health at different stages in our life, and a lot of people sadly go on to suffer issues around substance use, issues around bullying, all of those things that don't seem like nice things to talk about, but fair play to use for highlighting it and for raising it, and you might make the difference in getting someone else to speak up, so fair play.
Well done. Annie?
Thank you, Chair. Thank you guys again for that today, and for your video and the report. Obviously we've had really good engagement with you since we've started here with the tobacco and vapes bill, and now this, so this is fantastic. Obviously a very, very serious subject, and ones that you're committed to working on. Stigma came up again and again in the video and in a lot of your presentations. Do you think that more people, amongst young people like yourselves, do you think people are becoming more open about discussing mental health struggles? Who will we go for? Daniel?
I think a little bit, but it's definitely not where it needs to be, because I know, especially like in my school, if somebody goes to the mental health, to the wellbeing room, they're not doing well, and obviously that can lead to potentially bullying or even teasing about that. So ideally, just we get to a point where somebody goes to the wellbeing room and they're struggling with their mental health, will not say anything about that.
And can I say something? On one of the workshops that we had in our mental health stakeholder or mental health day in March, our workshop one was about stigma statements, and there's 12 of them, and stigma statement number 6 states that stigma around mental health is caused by our peers. So it is, and that is to do with that issue of either seeing a counsellor or seeing someone to get help.
Yeah, could I just add on to your point, Donal? If you look at stigma statement number 5, most of the young people said that they agreed that if we could talk more about mental health and if there were more space to talk about it, then people would feel more open. So if we could maybe implement more spaces where people feel comfortable in schools, like people said Zen dens and other places, then maybe it would help to also reduce the stigma, which is what most young people seem to think.
Thank you guys. I've never heard of a Zen den, but you know, I'll look that up.
I'm going to try and put a Zen den in my home. Sounds good.
So just one other question. I think it was Finn you'd mentioned about, it was either Finn or Brooke had mentioned about having mental health as a compulsory subject. What would that look like, and could that be encompassed into learning for life and work, just as it's in the school curriculum at the minute?
Yeah, I think it would be something that's put in with learning for life and work, but as our education committee was looking into, learning for life and work isn't a subject that's used as well as it could be or should be. Obviously, if you have mental health as a subject, the kind of things you're thinking of is talking to pupils about how they can manage their mental health, places they can go, teaching them about resources, and having that as a subject would then decrease the stigma on top of that.
I would say that mental health in the curriculum could be dealt with a session from an external organisation coming in once a term, and that's great, but it really needs to be more consistent. It needs to be something you have every week. It needs, and that would help. You're talking about stigma. That would help to get rid of stigma. Getting rid of stigma isn't something that's going to happen tonight. It'll be something that it'll take a long, long time to get rid of stigma. But the sooner we start it, the better.
Said.
Well done, guys. Thank you.
Oh.
Yeah, thank you, Chair, and thank you for your presentation. It's definitely given us food for thought, and I really appreciate the bit we ask the question about what should you do next, because we're certainly no experts, but we maybe have got some nuggets of advice. And the first thing I'd say is keep doing what you're doing, and especially from the issues that impact young people. Hearing from young people is important, but there is an important way to listen as well. You don't want to go into those ministers or go into places where they go, "Oh, aren't you all great and fabulous for talking the way you've talked," and then not take you serious. You've got a series of points. You've got real suggestions, and certainly what we need to do as a committee is to sort of maybe work on how we progress those ideas. I think the idea of it being a separate curriculum is absolutely it's a must, because whenever we were at school, mental health just wasn't talked about, so therefore you just didn't chat about it, you didn't talk about it, you didn't know anything about it. And then it's no surprise that whenever you become 18, 19, 20, 21 an adult, start to suffer from poor mental health, you hadn't a clue what to do because nobody had taught you about it from a young age. So I think you're really doing the right thing by trying to advocate that, so I'd say keep doing it. The one question that we have maybe is, given that you have those asks, sometimes what we would do in a committee is afterwards we would track the asks. We've asked the Education Minister, what have they said? We've asked the Health Minister, what have they said? It's that tracking rather than it just being a report, because we do say as adults, there's no point in a report and it just goes on the shelf and then nothing ever happens to it afterwards. So have you got some inbuilt mechanisms to sort of track this maybe in a few months' time as to whether or not people are actually listening to you?
Well, we have a new youth assembly coming in November time, and our work will always obviously pass on to them, but tracking it, it's very important obviously, and we hope to see obviously progress made through both the Health Committee, the Education Committee, and for other committees that are important in this. And as one of the things I learned in the video, one of the things is, it's more than a poster, something actually has to be done about this.
That's critical for it. And the other thing was on the issue we'd mentioned about social media and the use of mobile phones. Again, whenever you go to the older the person that's making the decision, the less connection they're going to have with social media and online activities, except Diane, she's all over social media. Don't be listening to what she says over there. But I think what's important is maybe the next, if you've got, I think we would call that a legacy report, that where sort of one committee leaves its legacy to the next committee that picks it up. I think it would be really useful, and maybe you could talk about to see if you think it as well, if we could have a conversation about social media and phones, because I think some young people think it's not great, but there's still a load of young people that think there's nothing wrong with it. And then if adults are all saying, no, we think it's bad, I think we all need to meet somewhere in the middle and have that conversation about it, so that young people say, no, well, look, using such and such isn't that bad. And then the adults can say, okay, well, how can we facilitate a bit of use but not taken away, but to try and meet, would that be useful, do you think? Or
so when the next youth assembly comes in the autumn time, there will be a few of us, there will be legacy youth assembly members, and we'll be following up on the work we've did in this term, and we'll be having conversations with the new youth assembly members. And I would be very surprised if the likes of social media doesn't come up again. And I'm sure we'll definitely continue work on mental health and social media. So,
you could have legacy MLAs, couldn't you? You have given us a really good idea today now to take forward, but yeah. Okay, thank you, Chair.
Alan? Thanks, Chair. Wonderful work, and not to patronise in any way, but true leaders. You do not underestimate the body of work that you've done, and how that literally will potentially improve the lives of young people of the future, and may even save lives in the future. I was quite struck that the analysis of the results, that bullying had dropped down to number 3, and I expected that to be much higher. In fact, I expected that to be top, given bullying nowadays is not something that is exclusively in the playground. It happens, at home. It happens anywhere and everywhere, given the nature of how it can appear on young people's phones. And I suppose on the back of that, and it takes me back to recent cases that I dealt with as a public representative, one that sadly saw a young girl lose her life, which is due to be broadcast soon on national TV, the story of, and another one where a young girl currently lies in a hospital with eating disorder due to being teased and bullied at school. And I'm just wondering, your own personal experiences, how effective in your own school environments have the schools been in addressing bullying? Because in instances that I have experienced, some young people and parents thought that in some instances measures could have been a little bit stronger.
I know in my school we have anti-bullying mentors, which are like people who are in 6th or 7th year, so they're similar age, so people feel more comfortable talking to them than to say maybe a teacher. And then if there's an issue brought to them, maybe they'll bring it to a teacher. However, I do still know there are people who feel that it still isn't good enough, and there should be more measures in place.
There's not enough done, I think, at all with schools. Sometimes it just feels like they're not there. They don't really care. I mean, in my school there's a few teachers that step up and deal with it, but I think as a school they don't do enough.
That follows a similar theme to what we have been hearing.
And I would say you're saying about you expected bullying to be higher. So it's number 3 on the list, but that's not saying it's still a huge issue. But there's just so many huge issues affecting young people these days, and bullying is definitely a big issue, and we're definitely not trying to say that it isn't a big issue. But bullying would be definitely a big issue that young people face today.
Well done from this committee to use.
Okay, Daniel, Finn, Donald, Christine and Brooke, that was excellent, so thank you very much for coming, and good luck with all your work, as particularly those then that will carry on into the next assembly, and keep coming back to this committee anytime you think we can be of help to you.
Thank you.
Thank you very much.
Thank you.
Okay, members, so we're moving on then to oral evidence in relation to palliative care inquiry. So can I refer members to the papers which are at tab 6 of the meeting pack? So including that as a written briefing, as at page 4, and there's also correspondence from the Regional Palliative Medicine group at page 43 of the table papers regarding the Minister's response on an issue of individualised care plan for hospital wards. Can I welcome departmental officials? So we have Geroid Cassidy, who's the Director of Primary Care, and Roger Kennedy, Programme Director, Community Care Director within the SPPG. And then for Children's Palliative Care, we have Ryan Wilson, who's the Director of Secondary Care. So, gentlemen, you're all very welcome.
Thank you very much.
Can I just hand over to yourselves just for some brief opening remarks?
Yeah, I'll make just brief remarks, Chair, and then we can get straight into the questions then. Good afternoon. Thank you for the opportunity to return to the committee today as part of the inquiry on access to palliative care services. I'm Geroid Cassidy. I'm Director of Primary Care in the Department of Health, and I have policy responsibility for adult palliative care and hospice services. I'm joined by Roger Kennedy, who's Programme Director in the Community Care Directive of SPPG, and by Ryan Wilson, who's Director of Secondary Care and has policy responsibility for children's palliative care and hospice services. We previously were here on the 16th of January at the outset of your inquiry. Since then, you've received written evidence from a wide range of organisations and individuals. Members have also heard oral evidence from a number of stakeholders, and importantly from people with lived experience of palliative care, as well as having visited hospices to see and hear about the valuable role they play in supporting and caring for people with palliative and end-of-life care needs. The evidence from the committee has received has clearly demonstrated the commitment, knowledge, expertise and passion of those who make up the palliative care community and of those who have lived experience of palliative care services. The evidence has also highlighted vividly the difference that palliative care can make for people with life-limiting conditions and their loved ones. We know that our population is ageing, with more people living with long-term and life-limiting conditions, often with more complex systems as their conditions progress over time. As our population demographics change, the need for good palliative care will continue to increase, and what those needs look like will continue to evolve. Helping people with a life-limiting illness to live as well and as fully as they can is at the heart of palliative care. As the committee has heard, good palliative care is not only about clinical care, but about the whole person, understanding and responding to the physical, emotional, social and spiritual needs of a patient. It is about providing care and support that is tailored around the person with the emphasis on their quality of life. Contrary to often held misconceptions, palliative care is not just about cancer, nor is it just for end of life, but rather a palliative care approach can be beneficial for years after diagnosis. In this context, palliative care can be part of and complementary to the business as usual of providing healthcare to patients depending on their individual needs. This is why it's important that palliative care is seen not as a service apart, but as an integral part of our health and social care system. As an example of this, the committee heard last week how work has been taken forward through the winter planning work with a focus on end-of-life care and advanced care planning within the big discussion. In addition, as part of a strategic agenda to reset our health and social care system, the department is looking towards the concept of a neighbourhood model, which will provide the opportunity to consider how palliative care is delivered in communities. The committee has heard evidence from colleagues in the Palliative Care and Partnership Programme and will be very aware of the role they're playing over the past nearly 10 years to develop palliative and end-of-life care services both regionally and locally. The department wants to further improve and develop palliative care and ensure that more people have access to the support and services that they need. To that end, the department welcomes the committee's inquiry and this contribution to that. We also welcome the opportunity to respond to the issues that you wish to explore and take any questions you may have. Thank you. Thank you.
Okay, thank you very much for that. I just have a few questions. So, we've obviously took a lot of evidence on this issue, and always the issue of funding comes up. So in your paper, the department saying it provides 50-50 funding for services, but that isn't what we hear back from those who provide particularly hospice services. So in terms of the detail of that 50, can you explain to us, the basis of the 50-50 funding? Is it, because what we're hearing is it's based on an equation that's not equal, and that you're basing it on a hospital bed scenario, whereas a palliative care with specialist services is much more expensive.
Yeah. Well, Chair, I'll respond initially, and maybe Roger can come in and some detail on that. So I think first and foremost, you're correct. The current funding model is 50-50. I think the first point we would make on that is that's 50% of the commission service rather than the total cost of that the hospice is incurred in delivering care, because hospices obviously deliver services that we don't commission from them, and they've got a wider care offering in that space. The comparator for that is based upon a general medical bed, and that's been the case for. You can keep me right in the detail on that, but it's been in place for several years. It was reviewed. It's been reviewed twice over the past decade, just to make sure that comparator remained appropriate. I think in 2014 and again in 2019, and in both instances it was felt that it remained an appropriate comparator. I think the...
Sorry, before you move on, just explain why it was felt that it was an appropriate comparator, because, as I say, all the evidence we have taken seems to suggest it's not a comparative comparator, and that you're assessing a hospital bed, general hospital bed, to something that's very, very specialist. So, I mean, I would like to know from your point of view why you think it is comparative.
Probably best person
to take that, Chair. So this is a long-standing planning assumption, goes back to 2004 in terms of the cost of the general medical bed used as a planning comparator, if you like. It is true that what Garrod said in terms of this is about meeting 50% of the contracted costs. It's not reflective of the hospice's actual costs in there. It's an interesting topic in terms of what good looks like as a fair and robust comparator that gives us value for money and gives a fair payment for that inpatient bed as well. There's no straightforward answer to what good looks like there. I met with Hospice Alliance, all the hospices and Hospice UK last week, and as part of our process for this year on the costings and any uplifts, and put it to them to provide us with a suitable cost, and they couldn't do that. So this is a challenge.
Can I come back to you just a minute? Sorry for interrupting, but just when these things pop into my head. So, I mean, you're putting the question to the hospice, but I could put the question to you that there are scenarios like for Antrim Hospital where they're fully commissioned palliative care. So, I mean, surely there can be an easily enough assessment of the accurate costs if they're fully commissioned and fully resourced in Antrim, from your point of view.
Yeah, I think to get a true, accurate, fair cost base, you would have to come up with a service specification for the inpatient provision, and that's something we don't hold at the moment. And that would be a driver, Chair, to get a full, robust, independent cost model in there, which would be essentially taking us into financial review again.
I think just to build upon what Roger said there, I think when this was looked at previously, it wasn't just as a single comparator was used. So there was looked at the costs of a general medical bed, geriatric medicine, thoracic and cardiology. So there was kind of a wider range of comparators were used. And that was work that was undertaken with expert support. Mary Curie were involved in that review. So, I mean, it's not just the department's view, and we have them engaged with stakeholders. Now, there is a. I mean, you've heard from evidence that some of the hospices they do think that we haven't got the level on that right. I think there is something around whether our costing per bed has kept pace with kind of growth in costs over recent years, and so there's work that Roger's leading on now to uplift that cost. So it's still a comparator with the general bed, but it's uplifting the cost of that. And then I said we had undertaken 3 years ago now to give a fuller, wider review of adult specialist provision, and that, as you'll be aware, we haven't been able to progress that as we originally intended. So we've kind of that's something that is not off the stocks, but it's not currently in the programme either at the minute.
Okay, and my last question on the funding issue is that, I mean, the hospices are running at deficits, a lot of them. So, for example, some are telling us that because of funding they won't be able to provide maybe services that they're currently providing, or in some cases, I mean, we've heard of a lot of inequality in service provision across the north. So some are providing services because they're funding for it and some aren't. I mean, has the department done any assessment of the cost to the department should hospices reduce the services that they're doing, because somebody's going to have to meet the cost?
Well, I think I'm sure we'll come on to the scoping exercise that we talked about previously. I know your comments last week, Chair, so I'm looking forward to that part. I think the understanding properly what the palliative care landscape currently looks like is a missing piece in our puzzle, and we said that when we were here. We really want to get a proper baseline on that. That would include what's been provided in hospices, but also what's been provided in community teams, and then it's obviously where the majority of palliative care is delivered is in generalist settings rather than in specialist settings. So I think there is work on that. If you look at the cost, we haven't looked specifically at what's the, if something were to stop here, what would be the impact here? But that would be, getting a proper sense of what provision is looking like, and I guess looking at where any commissioning gaps might exist will give us a better sense of what the costs are associated with that. So it's not going to ask the specific question you've asked, but I think it'll give us the information we need on the back end of it.
Okay, I'm sure other members will pick up and go into more detail, but just in terms of the scoping issue, so even in your paper, everybody has come before, again, funding and the scoping exercise has been sort of the butt of some criticism from the sector and those who provide the service. So even what we have received in regard to the scoping exercise, it's talking about what the department will do. It's nearly things in the future, but our understanding is this scoping exercise is ongoing. We've had criticisms about who's involved and who should be involved. So I would like maybe you to give us an up-to-date assessment of the scoping exercise.
Well, I think the first thing to say is that when I was here back in January, I was perhaps overly optimistic about how quickly we could progress that work. So I think when we spoke, I had said, with a fair wind, we'd be up and running in April, and then would be kind of 6 to 9 months to complete the exercise. We started work on. I wrote out to all of our stakeholders kind of in April to kind of set out the terms of what we're trying to achieve through this and trying to kind of make some progress on that. I think it's been slower progress than would have been hoped for. Part of that delay, I would say, is down to the kind of questions you've raised or issues you've touched on around what's in scope, what's out of scope, how you're defining this. I think we received correspondence from the committee on the back of some of your evidence around whether we should be looking at a specialist-only review or whether it was appropriate to look at it as in the kind of the wider sense. We remain of the view that the wider review is appropriate, the wider scoping, because that's primarily because that's where most of the care happens, but also to get a proper sense of where there might be any gaps in service. We had a really constructive, I think, meeting with the Palliative Care and Partnership Board 2 or 3 weeks ago, recently, where there was a PID for a project initiation document for the review was on the table then, which outlined the highlight, the kind of the key work streams of the review, what would be in scope, what would be out of scope, and how we want to progress that over the coming months. There was a pretty robust discussion at that meeting about, why is this why isn't this focusing on specialists? What is the scope correct? What do we mean by generalist, and how do you define that? But I think what I took from it was, I won't say there was unanimity in the scope, but there was consent that this was the right thing. That there was a good piece of work to be getting on with, and that they were content that we progressed it along the lines of what we had done. There are 3 work streams, if I can just make sure I keep myself right in this. There's 3 work streams in this. One is around the baselining of current provision. One is around a population needs assessment. So looking at, first of all, what the landscape is now, and the second strand is looking at what's the need that's out there that isn't necessarily been met. And the third strand then is around quality of care and the kind of the patient experience of quality of patient and service user experience, I should say, will be really important in that. That first work stream is scheduled to have its programme board meeting in August of this year. So kind of with leave commitments, it hasn't been possible to get it organised any sooner. So, and there are still some questions around definitions to be ironed through in terms of what we mean by specialists in general. But there is consensus at least that doing looking at the full service and not just at the specialist service is appropriate, albeit not quite unanimity in that. And the next order of business, once we get the group convened and get the kind of appropriate membership, is to set out the kind of the detailed plan and the timescale for delivery of that. The second strand around the needs assessment, we are likely going to go to an outside provider to do that for us. That's, well, we can keep it around the procurement, but we haven't yet got the provider for that. But we had thought initially the universities, but PHA may be appropriate to take it forward. So there's a piece of work just to kind of make sure we get the right procurement approach to that, and then that work can progress, and we have funding in place to allow that piece of work to progress. And on the third one around quality, really that the discussion at the Palliative Care Partnership Board was outlining there was a broad-based support for this piece of work, and we were looking for willing volunteers to participate in that work stream, and so there's more work to be done on that piece. So that's the general landscape. It hasn't progressed as quickly as we initially had planned, but it is fully in train, and I think some of what you've heard about, I know for example the Royal College GPs were saying they hadn't been approached. They were, through the Palliative Care and Partnership Board, all those stakeholders were approached, and everyone has had their say in not just the scope and the terms of reference, but in the plan going forward and the key objectives of it.
I mean, what, if you're saying they have been in the Royal College of GPs, or saying they haven't been?
It was after that meeting was after her meeting here, sorry, or her appearance here, I should say. No, but the meeting was already. It wasn't hastily arranged just to kind of cover up a gap. It was already at the plan that would happen.
I think some of the members may express deep disappointment that we haven't progressed further than that, and I mean you're not even really giving us a timeline for when a lot of this work is going to be completed.
We have a draft programme initiation document, and in that there is draft timelines at the moment, and for the completion of all three actions we're looking at April-May 26 for completion.
I'm wary of giving a false timeline that proves to be incorrect, but that is the current planning assumption.
Okay, I have lots of questions, but it will be unfair. So, Diane?
Yes, thank you, Chair, and thank you for the presentation. Where to start? I suppose the first thing I want to start with is this assessment of palliative care. Why did the department not have any ideas about what palliative care was out there, the extent of the palliative care that was out there, etc., etc., given that the department actually funds quite a bit of it? Why did you not know? Is that not a bit of negligence?
Well, I mean, I would say that we have got full line of sight on the services that we commission. And so for what the department is responsible for, we've got full line of sight now, and that is performance managed, and there is a contractual agreements for those things. But it is the case that there is, other arrangements are in place at local level between individual trusts and hospices or other providers. And I think because we're not involved in those contracting arrangements, we don't necessarily have full sight of what is in scope there. So one of the purposes of this review is to make sure we have a 360-degree view on what's out there.
So that in effect means that the department for the last whatever number of years has been content with a palliative care landscape that is full of inequalities, one where one trust will provide one thing, another trust might not provide, another trust provides something different, etc., etc. And you're now only doing the scoping exercise to try to ascertain the full picture of palliative care. Is that, that's
I think
probably where we are.
Well, I wouldn't characterise it in that way necessarily. I think that since the end of the kind of last kind of overarching strategy, there's been a lot of development in the palliative care space, kind of overseen by and with strategic direction, I should say, from the Palliative Care and Partnership Board, and that has led to commissioning at local level be it by trusts or from hospices and their providers. I think there's also hospices have been able to respond to emerging need more quickly and have maybe made services available, not just as needs. I'm thinking about say in response to COVID, but in other scenarios too. So there's naturally an evolution in things. I think the time is right now to kind of take proper stock on that, and really with the aim of, once we've got a proper, firm evidence base for what provision is like, and be able to assess, well, are there gaps or are there things that need to be addressed here, we can make some proper evidence-based decisions around how we do commissioning going forward. I think that, it really comes down to, effectively, there's been a certain amount has been commissioned centrally. There's been other local commissioning, if you want to call it that. And I think then our ability to have full sight in that is really important in that.
Gerard, you make a good attempt at responding to that question. But from the advice, and we've sat through hours of advice now here, and from the advice that we've been given from very senior practicing clinicians in the palliative care space, they do not believe that there is any kind of equality. They do not believe that there's enough information. They do not believe that every patient gets the care that they deserve. And that is very worrying. Just one last word from me on, you came to this committee, 10 months ago, or October or September, October last year, yeah? And you said that this exercise in assessment of palliative care need was going to go ahead. I think most people in this committee probably thought it was going to go ahead very, very quickly. And you've now given us a process which is really just how long is a piece of string, and it will go on and on and on. I would suggest, and I do this with a heavy heart, I'm not really trying to in any shape or form sensationalise this. There are people out there who don't have time for this, and they need you to act. And this kind of processing our way through everything, and I've been in government, I understand that process is good and it protects you, I understand that. But what you've described just now to the committee is a very long, extensive, exhaustive process where we, at the end of this mandate, could still be wondering what the whole outcome of it was. And I really do worry about that. Can I just go on? Everyone in this committee will have received a letter from Dr. Sarah Cousins and Professor, his name has gone out of my, Watson, isn't that it? Max, yes. And everyone will have received that letter. And in that letter, they detail the efforts that they have made to try to get the department to consider the individualised end-of-life care plans that are used in the rest of the United Kingdom. Why has that not been done?
Well, can I come back just to the previous point? I mean, I think when we were last year, it was January of this year. It wasn't the previous spring or autumn time. So just for kind of clarity on the record. And yeah, I've accepted it hasn't gone as quickly as we would have hoped. But I mean, I think we have got a timeline, and I think it's been worth getting the engagement right to make sure that we've got the scope of this right, and that we've got the kind of the broader range of professionals cited and understanding what we're trying to do. But it needs to proceed at pace, and it will. In relation to the individual end-of-life care plans, I think that there's been a lot of engagement, and there were differing views about the most appropriate of doing that. I know that representatives there have met with the CMO in the past, recently-ish, in the past kind of, I can't remember, was it 12 or 24 months, to kind of discuss this as an issue. There is, I think, how we are looking to progress that is as part of the advanced care planning and the name of the forum is escaping me, but the respect forum, I should say. So, I mean, it's not. I mean, we recognise that there's a need for standardisation as far as possible, make sure people are getting a kind of an equal level of care. The way we're looking to advance that is through the advanced care planning. I know you had colleagues last week here on that topic. When we're able to make the progress on that, on the advanced care planning and the standardisation of the respect process, I think that will deliver the same outcome as has been looked for by the individual end-of-life care plan.
So just my last word on that. This letter clearly states that a draft plan was presented in 2019 representing all multidisciplinary professions. We're now in 2025. Is this going to be, I mean, is the assessment of palliative care in Northern Ireland going to drag on in the way that this has dragged on? This is not something that can wait for people. This was presented in 2019. Response was received on the 27th of December 2023.
I think the response said that the processes that are in place here are in line with the current NICE guidelines, and that there wasn't, and it wasn't intended to move away from that in the current time. But like I said, the through the respect process as part of the advanced care planning, that is a way of getting the same outcome as.
But you accept that 6 years from this was submitted, we still are no further forward in getting this, except with more process.
Well. I mean, there's a lot has happened in those intervening years, and for amongst other things, the advanced care planning work really has its roots in COVID and the COVID response there. So I think it's material to kind of understanding some of the delay in some of this work. But I mean, I'm not trying to make an excuse for it, but there are mitigating factors for some of this.
I think most of the COVID response finished in 2021, and we stood up medical services that had been stood down at the end of 2020. So COVID, in my mind, isn't an excuse not to do this. It is really important to do it.
No,
I'm really, what I'm really getting at, Gerard, and I'm frustrated that something as important as end-of-life care has been put on the long finger by the department for such a long time. I think that most people listening to this committee today will be astounded that that's the way we're treating people in their most vulnerable moments. That's it, Chair. Thank you.
Thank you. Danny?
Thank you, Chair. Gerard, you mentioned the importance of keeping the record right there. In your initial submission, you said you thought it was 6 to 9 months that you thought it would take. I just went back to when you came into us there previously, and you were right, it was January, 16th of January. And the quote from the 16th of January from yourself said, "We are looking at getting the initial scoping work done in the next few weeks. The size and shape of the scoping exercise will determine how long it will take." In my mind, I am thinking 3 to 6 months.
Oh, sorry for misspeaking that. That's a mistake on my part for if I misquoted myself from earlier.
Okay, but it will depend on the final shape of the scope. However, we will keep the committee advised on that as it develops, as you're doing now. I suppose my question is, now we've heard that it will be completed in April, May 2026. By my counting, that's 15 or 16 months. So you initially told us 3 to 6 months. Now then it was 6 to 9 months, and now it's 15, 16 months. Has work actually started here?
Well, work has started. I mean, I put my hands up.
Scoping exercise started officially.
It started in the sense that the programme board is being established and will meet in August on that.
Hasn't had the first meeting.
The programme board hasn't had its first meeting. No. No, the meeting we had, say 2 or 3 weeks ago with the Palliative Care Partnership Board was to get broad agreement to the project initiation document, which set out what we're trying to achieve and the work streams, and then the next steps from that are to actually have the programme board meet. But I think what's been happening in the interim is a lot of engagement with stakeholders and providers to make sure that what we're looking to do was correct, to make sure we understood what evidence sources would be available and how we make sure we had access to the right evidence for it, and to secure some resource, to allow us to take the work forward in the way it needs to. I mean, because it is, taking this work forward is really, really important, but it does mean that there are impacts for capacity for other areas. So that's been part of the challenge. But I don't know whether you want to.
I'm happy to pick up on some of that. The complexity of this scoping exercise has not been straightforward, and it has not been straightforward collaborating with our partners in that and managing some of the expectations. So as simple as where do we start and where do we stop, especially when we go into the general side, has been hugely challenging, and we have taken our time on that purposely to a degree to stay close to the key stakeholders that will indeed populate some of these task and finish groups as we move forward. In terms of progress, certainly in key M2, we're progressing our procurement considerations, as Gerard said, potentially to go to a third party to provide that hugely planning and commissioning important piece of work on the needs of our population. So,
thank you for that. I feel we've had, over the last couple of months, we've had some brilliant briefings from palliative care providers, and we've met families and we've met patients and we've been at hospices. We've had really good information since we've last met you. I'm not seeing any progress here. We're told 3 to 6 months, then 6 to 9 months, and now it's going to be 15, 16 months. Is it realistic, do you think, that that's going to be produced in that time?
It's certainly our current planning assumption. And I think, I was unrealistic in my initial, I think I said in my comments, with a fair way, I wasn't trying to be as prescriptive as saying 3 to 6 months, but that was my sense of it. I was wrong on that.
Realistic now?
We've done more of the work now to actually bottom out what the work streams are and what the evidence sources are, so yeah, I think it's more realistic.
Okay. Just to go back, there's one thing that really sort of struck me. I think it was yourself, Roger, you were talking about having engagement with the sector. I think it was the Alliance of Palliative Care, is that correct?
Yes.
Palliative Care Alliance, and you have not been able to get a cost for service delivery, is that?
Part of that engagement is about the uplifts to this year's contract and maintaining that 50-50 funding. We have regular contact with Alliance and Hospice UK in there, and I'm grateful for that engagement. And we have been open with the GenMed bed and what that looks like, etc., to inform some of those conversations. As part of that, I think quite rightly, if there's concern about the existing fairly long-standing GenMed planning assumptions, that I would ask, is there anything across these islands that could inform a reconsideration of same? Now, I'm to follow up on conversations with Hospice UK, but at that meeting as of last week, there was no number that was offered in terms of a suitable alternative. So certainly in terms of that engagement, I will follow that up with Hospice UK and the Hospice Alliance colleagues in terms of teasing that out and see what exists across the islands.
The number you're talking about is the cost of service delivery. Is that correct?
Of an inpatient bed.
Of an inpatient bed.
Yeah.
Because we've visited hospices, we've talked to service providers, and we've seen statistics and facts and figures, and we've asked questions and we've been given the answers. So I'm surprised that you've been unable to get that number from the providers. Are you asking the right questions? I
mean, the question is quite straightforward in my mind. Yeah. We are using X number of pounds based on a general medical bed through the SPPG PLIC system. And if there's consternation on the planning assumption that we're using, what does a different number look like? So I hope I'm asking the right question and asking the specialists as part of a collaborative approach to inform that.
They haven't given you that number?
I've had their individual numbers, if that makes sense, because their cost bases can look different across those facilities.
So individually they've given you their numbers? So you've had some numbers from them?
I have had a difference in terms of the local hospice, what it costs them versus our planning assumption.
You have had an answer then, so you know how much an inpatient bed, the service delivery costs?
That in itself wouldn't be enough for me to make a recommendation to change the cost base. For me to change the cost base would have to be a financial review, and we would have to get into a service specification. So that's your skill mix, your standard operating procedures in terms of your multidisciplinary team and what we would pay for. Because there is variation in what is provided in that skill mix. If it all looked the same, that gives us a standard cost. Okay, and that would be a financial review in that instance.
So your plan is to do a full financial review then? Is that what you're saying? You have had costs from these providers, including the hospice organisations here, but that's not enough for you. You need to do a full financial review in order to
the last financial review was done in 1920. It is 2019 20. Sorry.
100 years ago.
Long ago, but not that long ago. And yes, I would agree. I think there is probably something for us to go away and think on a timely basis what a new financial consideration would look like.
It's just I find it shocking in that in our visits we've had presentations that have included these figures, that how much it actually costs to deliver it. So you know, I know you've just said that the hospice have given you figures and things like that.
Yeah.
So you have had those figures, what it costs them to deliver the service.
There'll be a piece of work to understand those individual figures there.
You don't understand
qualify.
them.
I think, sorry, if I can come in,
Sure.
I think the missing piece in this is that, you know, we had given a commitment in 2022 that we would do that full review of specialist adult provision, which would, I guess, encompass not just a kind of a crude bed comparison, but also looking at the kind of the full cost of all the service. That work hasn't concluded, and that would be a substantial piece of work, and it's one that, frankly, we haven't been in a position to do, you know, and that's why it hasn't progressed as had been originally planned. I think what Roger and his team are doing is engaging now to make sure that, you know, while still using that same comparator of the general medical bed, we're making sure that the value ascribed to that general medical bed has been updated to reflect kind of growth in cost base over recent years. So it's not the same thing as a full review that would maybe look at a different comparator, or maybe a higher cost comparator, but it is making sure that the comparator that we've used and that has been reviewed twice and was, you know, twice found to be appropriate, that it remains appropriate, but it's been properly updated or uplifted in the value of that.
I'm sorry to interrupt, Dan. I mean, I would like to be paying for a service today at the cost of 2019's cost, because I mean, I don't know anything that hasn't went up dramatically from those 5 years.
From that 2019, excuse me, 20 cost profile, that has been uplifted over those intervening years with the Agenda for Change, for example, etc. And the current process, Chair, will look at a new cost base, a higher potentially cost base for this year. And as part of that process, SBPG finance colleagues will be engaging with each hospice finance leads individually to bottom that out. And that may result in an increase in 25-26.
Okay. So the scoping exercise hasn't started yet, but you have had the price, you have had the cost of the service delivery from those organisations, and the work that's ongoing, hopefully will start to be ongoing, will be about understanding that.
Yes.
Okay. Thank you, Chair.
And just before we move on, this is a concern that I have. It's maybe not a concern of the committee, although I would imagine it's probably shared. I mean, Dan has made the point that this is such an important service and people can't wait. So, I mean, the Health Minister gets £8.5 billion, a lot of money, and we want him to be very efficient with that money. But we also want good services and good patient outcomes for people. And I don't want the department at any level to be looking at services in terms of how can I save money or reduce costs, as opposed to how can I provide an excellent service for the people who genuinely need it, and that then that service can be in somehow picked up by charities. I think that's an important point to make whenever you're looking at this. I mean, we've heard evidence, you know, the NI Hospice, for example, were up very recently. They provided what I thought was pretty detailed analysis of cost and the cost comparisons. So it may be worthwhile looking at their evidence, along with all the other evidence that people from the palliative care sector have given us on the cost. Because I think I can categorically speak on behalf of the committee that we do think that they're not getting 50% of what they're entitled to, and we actually think that they should get more than that.
Chair, I was in Northern Ireland Hospice on Tuesday afternoon and walked through some of those numbers with Brian, the Director of Finance, there as well. And that's in hand through the PLIX process in SPPG Finance in terms of any potential uplift in 25-26. And just for members' benefits as well, the contract will need uplifted with the Agenda for Change pay awards for 25-26 as well.
Linda?
To be fair, Chair, and apologies for being late. I was coming from another meeting, as was Nuala. Actually, Chair, you've kind of just covered it, and you know, other members had asked questions that would have been in my head as I was coming in. But I do think it's worth making the point again. It's really based on what you've just said, Chair. I understand that they've got an uplift in terms of the cost of things and the cost of services and the cost of staff and pay rises and all of that. But I don't think that even the staff in our hospitals would ever pretend to you that they deliver the kind of service for end of life that a hospice delivers. And we are talking about savings here, because there is trauma caused to families
and loved ones of somebody who does not have dignity in death. And that there is a significant cost to our health service in that, because it does leave behind it's a significant trauma and post-traumatic stress. So I just think that it's something that needs to be really considered. The organisations, everybody that's been in front of us have given us very detailed information. There's some really, really good solutions. I don't actually think you need to look too far for solutions, because the solutions have been presented here to us, and hopefully we'll be able to give you a report that will be helpful to you in any work that you do and that you carry out. And I really hope that the department and that the Minister listens to that, because there are solutions. Some of them actually potentially save the department money, because there is potential for replication of services. But the biggest issue, and members before me actually alluded to it, are the gaps that are being picked up by the charitable sector. That the reason that the department is having such difficulty scoping out and finding out what they are is because they are not commissioned. The department probably has no intention of commissioning them, and they've never been even considered for commissioning, and that's why. But they are very necessary. They are absolutely vital to the people who are in these circumstances and their families. So I just think there is a lot of work that needs to be done, but we want to be helpful as a committee, and that's what this inquiry is about. And we will certainly be using our report in order to ensure that what we think comes out of that in terms of recommendations that can be put in place by the department. That is what we want to see going forward, because we want to see best outcomes for people and their families. Those are more points than anything. I think they've been well covered by other members. I don't want to delay the meeting, because I know we have a substantial agenda today.
Oh, thanks, Chair. Gerard, the number of my colleagues made reference to timelines, and I'm going to throw another one into the mix. Number of the sessions we have had, the contributors talked about fragmented services, and one specifically was of Encompass. Could you tell us a bit about that body of work, given that hospices have only a read access only, and again a timeline? When do you expect that body of work to be completed, and have you any information on when you expect that fragmentation that is referred to by those contributors, that fragmentation in that specific matter will end?
Are you effectively asking when will hospices or providers get full access to Encompass? Well, as you'll be aware, first of all, I mean, Encompass has now been completely rolled out in all of the 5 health and social care trusts. The initial rollout plan for Encompass was limited to those 5 trusts. I mean, for a variety of reasons, financial being one, but also kind of operational capacity. It's taken us a long time to get to the point where we've got to with this. I think there is a desire to extend rollout to give full access to hospices and to other providers too. My understanding is that the hospices have been asked to do a kind of a combined, I don't know is bid the correct word, but make a combined representation to the Encompass Programme Board for how that would happen. I don't have the detail of the current status of that, but I'm not aware that there is a plan for it, or do you?
I think Diane maybe touched on this at last week's session in terms of minimum data set and the partnership with Encompass. Unfortunately, I can't give you a timeline on that. I'm happy to come back to committee and confirm what that timeline could be. But that's currently been worked up, as I understand, as a module of work with the Encompass team. Once that's confirmed and that module of work confirmed, there should be a timeline attached to that. But happy to come back to the committee and confirm that.
I think that would be helpful. It would allow us then to respond to those that have asked those questions. Thanks, Chair.
Okay. Gentlemen, sorry, one last question then for me, because nobody else has indicated. So, I mean, we have, well, when I'm asking them up, I would normally ask whoever's given the presentation, what are the 3 things that you think could make a difference? I mean, you're the department. We will be making a recommendation after the summer in terms of a report, which we hope, as Linda said, will be helpful, and obviously hope will be enacted upon. But, you know, in terms of the next 6 months, are there things that the department can actually do yourselves, even in advance of all of this, and in advance of the scoping exercise, that will improve services for for people who need them.
Well, I think from on the adult side, I think Roger's alluded to, I mean, there is engagement underway currently about just the funding level. I mean, not the full review, but looking just at uplifting that. So, I mean, making sure that the hospitals have got the kind of correct funding will be helpful in that space. I think something we haven't talked about here, and it's kind of, I touched on it in my opening remarks, is, and if you have had a chance to consider or what's been happening across the water in relation to the 10-year plan, I mean, we in the department are very much looking at what a neighbourhood model for healthcare would look like for Northern Ireland. I mean, PermSec gave an outline of that when he was here a few weeks back as well. I think there's tremendous, I mean, one of the key drivers behind that neighbourhood model is, number one, to deliver better outcomes for patients, but it's also to help better manage care in communities away from hospitals. And palliative care has a really, really important role to play in that. So it's not, I don't think in the next 6 months you'll see significant actions that will improve palliative care service in that sense. But as palliative care, as the thinking around how a neighbourhood model will work and how those kind of regional or local assets will be deployed to best use to kind of help manage care better and make less use of hospitals, I think palliative care will be a really important part of that kind of prevention and what's the word? I can't think of the word. In prevention of the need for care elsewhere. So that's the kind of the big things that are coming online. But again, it's not something that will see a big difference in the next kind of 6 months, as you mentioned.
Can I maybe add it? Just a further reflection. I know I haven't come in yet, but to pick up on what I think all of the members have said, and to reflect on while you come to your recommendations. There's something to be said about building on what's in place already. I know there's a scoping exercise, and that will be a detailed piece of work. There's detail on the costing to come. The Palliative Care and Partnership Board, and on the paediatric side, the Paediatric Palliative Care Network and the collaboration that exists between those are doing a good job, and we would fully acknowledge that there is a lot more to do. And I think you heard from clinicians last week and through the inquiry about the complexity of delivering palliative care across all kinds of environments and parts of the health system, and the need for better education. So those structures are in place, and they're doing a good job with what they have. And I mean, I know your recommendations won't materialise new money to come into the system, but we would hold our hands up and say, with greater capacity to do that work. I mean, what they do is provide capacity within clinical leadership to do this work, to develop regional pathways, to promote collaboration across the system and across the sectors, and to promote that public health approach, which I think you heard about last week as well. So the system is doing a bit of that, could do potentially a lot more, and that's not a criticism of anybody. I'm just saying that the system is not doing nothing at the minute, waiting for these other important pieces of work to do. There's foundations and progress that I think can be built on and supported, were there to be more investment available to put into those.
Thank you very much. Appreciate that. Okay, members, just to advise, that actually concludes the oral evidence from the inquiry. So the committee has given a deadline of tomorrow, 4th of July, for any further written submissions to be received, and then we'll consider its draft report, or we will consider a draft report after recess. So can I just, for the record, thank all the organisations and individuals who have provided evidence to the inquiry. I think everybody will agree the nature and excellence of the evidence that we have received has been just that, and it will be very, very helpful to us. So thank everybody who did provide both written and oral evidence to the committee. If members are content, all correspondence, including responses received from the department in relation to this, are published on the inquiry webpage. Happy? Okay, and then just also to say that I have asked committee staff who will be working on the inquiry over the summer that rather than us just be in limbo till we come back after recess, that over the summer, I think hopefully in the first week of August, we will get sight of draft recommendations, so that will allow us at least sight of that, to have that thought in our head, those thoughts in our head for when we come back. Dan?
Chair, it's just a point. We received the briefing, I received it today from the department. Getting briefings of that length and complexity and such a difficult subject is really brought on the same day, a few hours before the committee. And I think that we should remind the department that they've known about this for a long time. This has been in the diary a long time. It is not good enough to send us a briefing, you know, a few hours before the actual committee meeting.
It's actually a point I meant to raise a couple of weeks ago, because it's not even just in reference to that.
No, it's a lot of the time.
We're receiving written briefings from the department today on other things that are on our agenda today, and you know, some of us have other meetings, like the policing board members have.
Yes.
You won't get a chance to read your table papers, and the rest of us could be travelling and whatnot. So I think we should go back to the department in relation to all of the evidence they're providing, the documentation, briefings, written briefings, that we get them. I mean, they know when we are our committee papers are going out, and they should be included initially in the first committee paper. Yes.
Sorry, from my perspective, that was a waste of time. Not on those guys, but we're doing a scoping exercise, and we might start it in a few months' time. Well, what's the point in asking them questions?
Yeah.
Well, almost. If they come at the start, what's the point of the inquiry if they're everything that we're raising and everything that's discussed and there has been oodles of hours spent on that, and then they're saying that basically we might start a scoping exercise to look and see what's out there. So they kind of felt if they had told us that at the start, you might actually have deflected what you were doing for a year, because we have been finding out what is actually out there and then wondering where the gaps are, and then they're coming in and we're asking them about the gaps, and they're like, well, we won't know until we do the scoping exercise. It just feels like it's been an interesting jigsaw to put together that way.
Yeah. I'm still confident that our report and our recommendations will be.
We'll do the work for them.
It'll be the scoping exercise.
Yeah.
The
scoping.
Needs a name.
It will do. Anyway, so we will look forward to seeing the draft recommendations, and then obviously working on the full report when we get back. So moving on, then, members, we're taking oral evidence on the cytology screening review. So can I refer members to papers at tab 7 in our packs, which includes a written briefing at page 176. And can I welcome Professor Lourdes Gagan, hopefully I pronounced that correctly, Deputy Chief Medical Officer within the Department of Health, Paul Kavanagh, Director of Hospital Commissioning within the SPPG, Dr. Joanne McLean, Director of Public Health within the PHA, Stephen Austin, Medical Director, Southern Trust, and Moira Kearney, Interim Director of Cancer and Specialist Services in the Belfast Trust. I should point out just at the beginning that we also have representatives and individuals from Ladies with Letters in the public gallery, and we welcome them to the committee in the public gallery as well. So I'm going to hand over to yourselves just to make some brief opening remarks, and then we're going to take questions.
Thank you, Chair, and thank you, members, for inviting us. You have quite a few of us, but we appreciate the matters are pretty complex, and hopefully we have the right people to cover the right areas that you'll have questions on. I'm going to say just a couple of words in opening, and Chair, if you need me to move on in terms of time, happy to do that along the way. So, in advance of today's meeting, we did provide Chair and members with some written information. I'm happy to answer questions in relation to that. My colleagues here will answer those if you have questions arising. Before we go any further, we really want to begin at the outside by saying that we're all very conscious of the patients, the ladies, the families that are at the centre of all of these matters that we've been discussing. They are very complex matters. And we are very conscious, as we have been right through, and the Minister has been right through, of the impact on individuals, on their family members, on their supporters and carers. Minister, the Department and I certainly acknowledge that the last number of years have been very challenging in this regard for a group of women impacted and for their wider families, and as Minister has said before, and I say again today, it is deeply regrettable. I also want to acknowledge that, as I've said, the matters are complex. So we will endeavour to answer them in as straightforward a way as we can. We want to reassure members at all times that we are trying to keep the discussions as straightforward as we can. Please do ask us questions and interrupt if we're not being clear in terms of the answers that you're seeking from us. There are currently 8 screening programmes in Northern Ireland, 8 population-level screening programmes in Northern Ireland, and 3 of them are cancer-related programmes, and the cervical screening programme is one of those. In relation to policy, the department is guided by the UK National Screening Committee, which is a committee that sits in London. It's an independent expert committee, and it advises ministers and all the health departments in relation to policy matters and evidence-based research and so forth around population screening programmes, all screening programmes, not just the cancer ones. We also have the Northern Ireland Screening Committee, which is chaired by the Chief Medical Officer, Professor McBride, and that takes matters which arise from the National Committee and looks at them in the context of Northern Ireland and advises accordingly and advises Minister and the Department. And then obviously it's Minister who considers and decides on the screening policy for Northern Ireland. There are a range then of organisations involved both in provision of the screening programmes and in their oversight and assurance. For the cervical screening programme, the providers include practically all general practices, all of the trusts and the business service organisation. Okay, and that's because there are complicated infrastructural pieces behind the screening programmes, IT, call and recall mechanisms and so forth. In terms then of delivery of the programme at a regional level, obviously SPPG and my colleagues in PHA all have very important roles in part of the delivery, part of the oversight and part of the assurance of the programme. So for governance and oversight overall, there is a combination of systems running. There will be matters running in individual GP practices who might be doing tests and smear tests for ladies. There will be matters running in trusts which do a small amount of smear tests but provide a lot of the laboratory services. There will be matters running at a regional level for the Public Health Agency in relation to partially commissioning the programmes and providing quality assurance across the programmes. There'll be matters running for my colleagues in SPPG who do a range of work in relation to quality and service provision and funding, as you know. And then within the department, obviously, we'll be looking at policy. So there's a range of complicated pieces going on across any screening programme. So directly in relation to the matters at hand, following the provision of the Royal College of Pathologists report to the Southern Trust, the department established an additional oversight committee, and that's called the Cervical Screening Oversight and Assurance Group. That's an additional group to receive assurance about the improvements and the work that needed to be done to address some of the problems that were arising in cervical screening. And that is co-chaired by myself and Peter Toogood, Deputy Secretary, Grade 3, who has the overall policy responsibility here. There's a range of organisations represented on that group. That group would have met weekly when it started its initial work, and now it meets monthly. Minister's aim overall, which we as a department are charged to serving, is he wants to understand very clearly what occurred in relation to this screening programme, particularly in relation to the service as it was delivered in the Southern Trust. He wants to understand why it happened. He wants to understand what the responsibilities are across it. He wants to understand that lessons have been learned and that such matters will not happen again. And we are all charged with ensuring that we have a high quality, well-functioning screening programme, the aim of which is to reduce and eradicate as much as we can cervical cases of cervical cancer in Northern Ireland. So in order for Minister to reach a conclusion to those questions, a number of things have been ongoing, and I think you'll probably have questions in relation to some of these pieces of work. Obviously, the Royal College of Pathologists did their piece of work, and that report was published with a number of recommendations. All of the recommendations in that have been implemented. There were recommendations for the Trust and there were recommendations for the region. And one of the very important recommendations in that is that we would move away from using cytology, which is laboratory-based making slides, that if we looked under a microscope, we would move away from that test, using that test as the first-line test. And that has now been fully implemented, that it's HPV testing is the first-line test. Following on from the College of Pathologists report, you will be aware that the Southern Trust and PHA jointly undertook and oversaw the review of slides of about 17,500 women. The majority was a look back, some were called forward to look at, and the report of that work and the look at all the cancer data from the Cancer Registry, those two reports were published in December last year. There are a number of other pieces of work which are coming to a conclusion now and which Minister intends to publish. So we have 3 other 3 to 4 other pieces of work which are coming towards a conclusion, and Minister has advised his preference is to publish all of those together. And they include an expert opinion on the 2 reports already published, and that external opinion is from experts outside Northern Ireland. The report of the peer review visit which NHS England undertook to look at the quality assurance piece which lives in PHA. That report has been just literally received by PHA, so that will be going into the mix to publish together. And then there are a number of learning reviews ongoing which involve patients, predominantly patients who are receiving care in the Southern Trust, but not only in the Southern Trust. They are also reaching a conclusion in terms of the process, and Minister's preference is that the recommendations of those will also be published at the same time. So we are now coming to a stage where we will shortly be able to look at timescales for publishing the rest of those reports as well. And I flag that because it is difficult to understand across the whole piece until all of the reports are available to people and people can look across the piece. So that's where we are. We will be happy to answer any questions about individual pieces along the way of that journey. We're I would say, probably 2/3 to 3/4 of the way through getting all the various pieces looked at and the various reports. Just before I conclude, I just want to say a couple of very short things about screening programmes and particularly cervical screening. As I mentioned, the matters are complex. All the services involved in the screening programme are delivered through our trusts and GPs. They are delivered in the same way as the services for somebody who is symptomatic are delivered. So people participating in the screening programme should not see a difference between what is necessarily a screening service or what is a diagnostic service. But when we look at them in terms of oversight, management and functionality, they are quite different. And that's sometimes why the conversations can be quite complex. So forgive me if we're giving a bit of context around some of the answers to your questions, because sometimes we have to explain the context for a screening programme which might be different to a diagnostic programme. The other thing I really wanted to highlight is I suppose all of our focus on ensuring that we continue to have good participation in this screening programme. It is possible to probably almost eliminate cases of invasive cervical cancer as we go forward. We have a vaccination programme which is delivered in our schools and through some of our sexual health clinics. Again, we'll be happy to answer any queries you might have on that. That's been running since 2008 for girls, 2019 for boys. That is reducing the prevalence of HPV infection, and HPV infection is associated with cervical cancer and a range of other cancers. So a combination of the vaccination programme and a good screening programme with good coverage will be what will get us to reducing our cases of cervical cancer to a minimum. I'm not going to use the word eliminate, but it is possible to reduce the incidence of this cancer significantly. And we are all focused on getting to there and on supporting people to get to there while understanding if and when things went wrong in this programme, what happened and how it's remedied. So I'll pause there, Chair, and we're very happy to take your questions. Because the matters are complex, I'm happy to maybe direct members' questions to the appropriate colleague if that works for you.
Yeah, absolutely. One question I have, you said you're 2/3 of the way through producing the 3 reports for publication. Can we have a time frame for when that's likely to be the case?
I would think, now obviously we don't want to be publishing in July when people will be going on holidays, but I would say once we get into August we'll be looking at dates towards August, September. So it's imminent. In some cases the reports are just being finally factually accurately checked and concluded. In other cases the peer review report has been received by PHA, it's been considered by the board. Minister has literally just had sight of it, hasn't had a chance to consider. But the most important piece is that the learning reviews involving the patients are just coming to a conclusion. And what we wanted to do, which was really important to Minister and to us, is that people involved in those have a chance to meet with review teams, to ask their questions, receive copies of their reports, and we don't want to impact on that timeline. So once that's done, we will then plan towards getting the others published. But I would say it will be short term, it won't be extended well into the autumn time.
That's helpful. I'm just going to move around to members. Linda?
Thank you, Chair. Thank you for the presentation. The first point I just want to make is a number of members will have been contacted in relation to a specific case, and I don't want to breach any confidentiality.
Yes, yeah.
The department has received that I have forwarded it on, I'm sure other members have as well, And I definitely think we would want to have a conversation, because that shows that problems still exist, even in terms of how people are dealt with, you know, on a human level, on a very, very human level, and how these things are managed, and confusion between trusts about, you know, who's given what information, who's dealing with meetings. Like, that's just not acceptable. So we will want to do follow up on that, but that's as much I'm going to say about that, just to respect confidentiality. There's a lot of detail provided in the decision-making process for the single site of HPV testing, including the need to do a minimum of 1,500 screens per annum and checkers to do 1,000 screens to maintain competency. So the words sustainable, resilient are used, and they're extremely important. But can I get some detail on what it means for the accuracy and therefore the outcomes for women? That's my first. Do you want me to give you all the questions?
Happy to be guided by you, Chair. It might be, because they're complex, it might be easier to take each question if we can.
And mine are not.
If that would help. In terms of service configuration, I'm going to hand over to Professor McLean, but just to say to you in relation, and I am very mindful of confidentiality, but in relation to the individual piece that you spoke about earlier, we have received that feedback. Minister has received that feedback. We have shared that. I've shared that confidentially with senior staff in both trusts, and I've asked for it to be addressed urgently in a integrated way, so that the re-engagement and feedback with the family in question is done in an integrative, supportive way. So just to give you that reassurance.
And Joanne, specifically on the question, so that you know, what does this mean for accuracy and outcomes for women, because of that piece around competency? Because we have all the detail, and I know I'm very conscious that other members will have detailed questions, so just rather than, so it's specifically around that, the accuracy and outcomes.
Okay, so the first recommendation to move from, at that time, 4 laboratories to 1 was actually made in 2014 by the Pathology Network. So the Pathology Network is just what it sounds like. It's a network of all the different laboratories working in pathology across our trusts, and they come together to provide advice to commissioners, advice to the service and guidance and things. And they actually recommended back in 2014 that we should move to a single site model. So we took the decision to move to a single site model for the reasons that you have outlined, really about resilience, sustainability, and also around the outcomes. Just to give you a kind of flavour of the numbers that we were talking about, we were going from doing between 110 and 120,000 cytology reviews a year down to about 14, 15 really, really quickly. And we expect that number to reduce further for a couple of reasons. The first driver of the reduction will be the introduction and the success of the HPV vaccination programme. So as we get young people who are vaccinated and come into adults and come into screening age, the prevalence, the amount of HPV in the population will go down. So actually the number of slides that we receive that are HPV positive that need cytology is actually predicted to fall further, maybe by about half over the next 10 years or so. So that's one of the reasons. Whenever we looked at models across the UK, in England, there are 8 laboratories.
Joanne,
Yeah.
I appreciate all this, but that information is in the paper, so it's really, for me, that's why I'm saying I want to understand what does this mean in terms of accuracy. Like, does this give us a greater, because of that 1,500 screens, that will be fulfilled?
That is the aim. So the aim is to create a team who are seeing enough volume and getting enough practice and doing enough continual learning with each other, professional development, training, that there's enough of a size of a team who are able to deliver that. So that learning, and that will give you better outcomes. It also allows sort of the assessment of how well the lab and the individuals screeners are doing. It makes it more streamlined, and it should be more accurate and therefore lead to better outcomes in the laboratory.
I appreciate that. So then on the back of that question, were the trusts meeting the levels of screening to ensure competency? Because if that recommendation was made in 2014, had that recommendation been carried through at that point, you can't give any guarantees in this, but would it have given us a greater chance of people having the competency to ensure that what happened didn't happen?
Well, I think a reduction in laboratories would have been some help. However, I think it would have been difficult to reduce the total volumes that we were doing the 120,000 into one lab, that would have been a very big laboratory. So I think that the recommendation was made in 2014 in the knowledge that both the HPV vaccine was going to reduce prevalence, and as well as that the introduction of primary HPV would further reduce cytology. So it wasn't carried out in 2014. Any sort of reconfiguration of any service is a difficult thing to do, but it was really important that it was done as part of the introduction of primary HPV. So we got a lab that was big enough to deliver a good outcome for women.
So I appreciate that, but I don't think we can rule out, had that been done sooner, that we may have had a different circumstance today. I don't think we can rule it out. I'm not ruling it in.
I don't think we can say, but I think it would have been difficult. I wasn't involved in 2014, but I think it would have been difficult to have squeezed all that activity into one lab, because that's a lot of cytology. Now that's, so I think it would have been a challenge. It was a challenge even to do what we did, and continues to be a challenge as the service gets up and running. But certainly going forward with one laboratory, the reason and the aim for that is to give it a better outcome for women.
I have two other questions. Just the reduction from screening from 5 years to 3 years, and I mean that's based on the HPV testing. Can I just get some understanding, because I didn't really get it from what's in the papers, other than it's because of HPV testing. Can we have confidence that reduction in periods between screening, so or increase in period rather, from 3 years to 5 years, have we strong evidence, given that HPV testing is not that long in place anywhere?
So, first of all, to say we haven't changed the screening intervals here in Northern Ireland as yet. The other countries have at this point.
There is a plan to, based on the
there is
at least under strong consideration.
It is under strong consideration, but there isn't a timeline associated with the plan for a couple of technical reasons, which I can explain to you. But the national evidence and advice around this was provided by the National UK Screening Committee, and they gave that before 2020. I'm going to say even before 2019. Wales and Scotland moved in the years before 2020. I don't have the exact years. England moved pretty recently, so they will all be generating evidence in this regard for any of the nations who have already moved, and we will be able to use that evidence. We haven't changed any of the screening intervals as yet here, because we've just moved to primary HPV in the first instance, but secondly, it needs IT and technical development behind it, and the digital teams are currently looking at when is it even feasible to do the digital development on this, because of as you know, we've got Encompass, we've got a new laboratory information system, and all of that is tied up in what can be achieved digitally. So I suppose in summary, we'll have evidence from the other countries. The other thing we will need to take account of is, as the prevalence of something falls, if you're screening too frequently, that is also a risk to the population, so we need to balance them up. But we don't have definitive dates as yet.
Okay, I understand that, and just if we can get some feedback in relation to that whenever that becomes more apparent.
Yes.
So just in page 224, Chair, there's a paragraph that talks about, in the HPV test, and this is that, individual trusts, we're still talking about individual trusts making a referral to HCPC, and if there's a concern regarding performance of screeners, does that mean that will be entirely under the responsibility of the Belfast Trust? And what is the oversight of this? Because this is something that I have raised consistently, is what was and what is now going to be the oversight of this in terms of PHA or whoever that oversight body is, because we can't allow the same thing to happen again. So I mean, the ladies with ladders have actually raised this in a slightly different context, so they're looking at the past, I'm looking at where we are now and what the oversight is now, but it's the same issue. I don't really understand why the oversight didn't kick in the Southern Trust, and I want to make sure that it is going to kick in any future issue.
Because I think you're talking about laboratory services and the overall screening programme. You're talking about both, okay.
You're thinking about, because that's a question that I think all of us had at the outset. Gosh, this was a long time. How did that happen? So the review that we got done by NHS England. As Lurda said, we received that, I think, the week before last. So we've had a look at that. And one of the recommendations it makes is around how we strengthen things going forward. So it makes a number of recommendations in terms of how we do our sort of how we interact with trusts from the PHA, how we specify what we expect from them. So there's been a lot of uncertainty around the data, because remember the discussions we've had in the past around how it was calculated, how we should be clearer about standards, how we should be clearer about the specification and things that must happen within the lab, and then it's not optional and you can't do a different thing. But also, really importantly, they have made recommendations as to how we in PHA should get some external, and I mean outside of Northern Ireland, assistance with the QA, because if we move to one laboratory, we won't have that independence from a QA lead. So we're looking at the recommendations, and they have made some specific recommendations about how we secure external expertise to do that very specialist laboratory QA in the future. So I think we've got the recommendations from the NHS England peer review, and the recommendations are helpful, and I think we will put in place a plan to implement those, but one of those is specifically around how we QA specifically around the laboratory.
Yeah. Two last points. We definitely need to get a better understanding of that, what it's going to look like. I mean, I would like to think when all these reports are published that you'll be back in front of us, that we can have these conversations with you. That my final point is, in terms of the reports when they're published, and I know this is something that the ladies, but not just the ladies with ladders, every single person who obviously is affected by this should be entitled, I think, to have, if they wish, sight of that report. Not everybody will want it, but is there a way of working that out? Because it has been done before, Lurda. Like, I mean, I've dealt with the HIA stuff, the mother and baby, Michael and Laundry stuff, and there has been a process put in place whereby victims and survivors are given the information. It may be very short time prior to publication, but they're given their place, you know, and they're just given that information. It's just it's as much about, I'll go back to what I talked about at the very start, it's about that humanity. It's about making sure that the people who are most impacted are given their place in this. So I just think that we should be going back to the Minister. I'm asking you as his advisory team to go back to him and ask him to look at how that can be done. That doesn't mean everybody will have access to the report. I do think it has to be that the people will be offered it, and who takes it up. But at least the offer should be there. There has to be some way to put that in place.
Confirm, I'll be happy to take that back to Minister and discuss it with Minister.
I mean, I think it could be done on a confidential basis. I think if we're entirely honest, reports have been leaked by people that were not victims before and were not people who suffered because of certain issues that have been reported by, leaked by people in this building. So
I would be happy to take that back and talk to Minister about it. I think for us, we hear a range of views on this, and we hear very strong views about wanting prior knowledge and prior information. We also hear the opposite, and I've directly heard the opposite myself, of people saying that they wouldn't want it. So we're trying to balance a range of things, but I am content to take it back from today's discussion and talk to Minister about it again.
I mean, it could be done in a time frame. That's the way it's managed in terms of the mother and baby stuff. It's done within a time frame, which can be constrictive, and I acknowledge that it is constrictive for the victims and survivors. So it's not ideal, it's not perfect, because you are trying to meet the needs of many people. But I think that we have to find some way to manage it. It has been found in other circumstances, so we know it can be done. Nothing that will be done in this circumstance will be perfect. I think we just acknowledge that now, that we're not in a perfect situation because of the harm that has already been done. So we just have to acknowledge that. Thank you, Chair.
Diana?
Yeah, thank you, Chair, and thank you for the presentation and for coming back again. Can I, at the outset, say that there are people in this room who are deeply, deeply involved in this, and we owe them thanks for the way that they've persisted in trying to get answers for their loved ones, and some in this room have lost loved ones. I suppose every time I return to this, it raises more questions than it answers. And that's why, at the end of the day, we will need an inquiry that actually establishes the truth about this, notwithstanding the reports that are due this summer. Can I go back, first of all, to the issue of screener data, which I think is massively, massively important. And this committee has been asking for the individualised screener data across all trusts for a very considerable period of time. And I notice that on page 187, paragraph 45 of the presentation today, you're still analysing this data in order to present it to us. And I'll say more about that in a minute. But I was given this morning a determination from the Information Commissioner's Office, where I think it was UTV had asked for the same data, or maybe data from a limited number of trusts, whatever, similar data. And the same excuse was used to UTV as it was used to this committee, which indicated that, no, sorry, we can't give you the data because it might identify individual screeners. And I have now the decision by the Information Commissioner, which says that the Information Commissioner says that this is not true, that the data should be provided, and it should be provided in the way it was requested, and it has to be provided within 30 calendar days of this notice. That was issued this morning, 3rd of July. Why is the Trust and the PHA so hesitant to provide us with the data? And why, when the Information Commissioner, having reviewed your submissions and the request, the Information Commissioner says that there is no reason why this data cannot be provided in a way that individual screeners cannot be identified? The data that was provided to us as a committee is generalised data, which is of very little use to us in assessing screener performance. And it was screener performance that was key in this whole issue. So can I have some thoughts on that?
So I'll answer from a PHA perspective. So we did receive an FOI some months ago, and initially I think the determination was that the data wouldn't be released for two reasons actually. Part was a worry about identifying individuals, but the other reason was it was the work that was required to do it was above the FOI limits. Now the person who put the FOI in appealed that, and within PHA that was considered through our appeals process, and we responded to say that we will provide the information to the individual, but we couldn't do it within the FOI window, and that is because it genuinely did take a lot of work. We now do have the data. So we've pulled the data, we have gone through a process that we've had to check it with the trusts. One of the issues, the data around this has been really, really hard to understand. I mean, I as a public health person have found it really hard to understand why it has been so difficult. But one of the things is, unless you calculate it in a really specific and particular way, you will get a different answer every time you do it. And that is one of the problems that we've come up against. So the data has been calculated. It has been reviewed by the trust. They have all come back and said that they are happy that what PHA has produced is an accurate reflection of their data and is calculated in the way that it's been set out. It is being finalised, and we do hope to be in a position to release it both to the FOI requester and to the committee in the next number of weeks. So we do have worked on it. It wasn't as simple as just typing it into a computer and it all coming out. There was a lot of work and went in behind it. So as I say, within PHA, we had taken the determination that it was in the public interest to get the data, but we just needed a bit longer to do it.
Why did you use the excuse that it could identify individual screeners? I'll read for the record of the committee, I'll read the paragraph 24 of the decision. The Commissioner considers that the Commissioner 24, he can't see how a specific screener could be positively identified from the figures only, and the Trust hasn't made a compelling case that this would be possible. That's what you've told us for months and months now, and the Information Commissioner has now decided that that's not a relevant consideration.
I maybe come back on the identification. I think there was, from PHA's perspective, and I can't answer for the trust, and I personally have not seen that determination. It's one for the trust. I think the concern was that if you went down to, say screener A to Z, and then you had them the following year, you would be able to tell, well, screener A worked between X and that must be person X, because there was a bit of concern around that. Now, as I say, within PHA we did take a determination that this was information that was in the public interest, and we are going to provide it and have work to do so. Unfortunately, I haven't seen that particular determination. But
you can understand why this raises a lot of concern for us. When these are the lengths that we're going to, we are a statutory scrutiny committee and we haven't got the information. The Information Commissioner is saying there's no reason why the information cannot be released, and we're still weeks away from getting the information. I think, and I mean, and this is part of the problem in this whole episode, is this failure to supply information in a timely manner. So just to go on from that, because it is really important about the data and the information. So I am reliably informed that the PHA sent data to each trust, and there is something called an annual data visit with each trust from the PHA on screening data. So, I mean, I'm just a simple politician, so like, who am I to say this? Why can we not have that data that's supplied every year?
So I would need to check this, but I think that data has been supplied on previous occasions. I think what was asked for in the information request was individual screener sensitivities over a very long period of time for all the screeners. So it wasn't just looking, this is the 10 screeners who worked in 2025. It was going right back, so there had to be a bit of a historical look. But
if we had that data on an ongoing basis, we would be able to assess screener performance. I'm presuming that data indicates screener performance. And we would be able to assess that. You're bound to have been able to assess that.
That's one of the things that the trusts and then the PHA so as part of what the trusts do in the programme, they constantly look at the data and take actions wherever it deviates. And then part of the data meetings and the quality assurance meetings that the PHA has with the trust is to review that data on an annual basis. And where there are deviations where people are not meeting the sensitivities, the reasons for that are explored and remedial actions put in place. I think, and we've said this before at the committee, I think one of the issues in the Southern Trust was that in the past there wasn't the data wasn't viewed over a number of years. So that there will, if screener A has underperformed this year and you say, oh, we'll fix this by doing X, Y and Z, there wasn't a robust enough process of going back and saying, well, did they underperform the next year and then the next year? And that's something that we've accepted before as something that needs to be improved, that it needs to go over a number of years. But yes, it feels overly complicated. I want to assure that I certainly want to be as transparent as possible and provide as much information that is accurate as possible, because one of the difficulties has been that you get different figures depending on exactly how you run it, and that has been a challenge throughout the process.
Can I move on, because I think it is really unsatisfactory the way that data has been withheld, the way there's clearly an issue about the way data was scrutinised and quality assured in the Southern Trust. I am told there may be an issue in other trusts in relation to that as well. And I think that there's a real issue around the data, and the fact that people are having to go to the Information Commissioner to get resolution there in relation to the release of that data is really, really, it's appalling actually. I think that we in health should be much more transparent than that. Can I ask, again, Linda alluded to the SAI process, and I'm conscious that this is a live issue. And that there are people deeply, deeply affected by it. But there were 12 cases that were to be reviewed under the SAI process. Can we, I don't want any individual or private information at all. Can we get a roundup of where those 12 cases are, etc., etc.? And Lorda, you now know about the horrendous circumstances in which one of these cases was dealt with. Have any others been dealt with in that way? Or have you known of any others to be dealt with in that way?
I'm going to hand over to Stephen, first of all, about your question about where we currently are, or where the Trust currently is with the overall process involving the 12 cases.
And thanks for the question. First of all, just like to note that we are very conscious of the hurt that people suffer with the disclosure. What we've learned from the SCI process so far is that disclosure is a very difficult thing for women to hear the results of their the audits of invasive cervical cancer that take place in itself. It's very, very challenging. What is also becoming clear is that the actual process for doing that is not helping to share that information with women. I think this has not really ever been looked at, particularly across the UK, how the disclosure process has been done. There's broad guidelines, but they're not being reviewed. One of the things we have been looking at, and we asked in the SEIs, the more recent cases, was specifically look at disclosure, because we had a large number of cases at once, to try and get some learning for that. So at present, you asked about the current situation. The SAI was a multi-patient SAI for 12 patients. That's nearing conclusion. There's a bit of listening to take place with a number of families and women at present. We expect that to be concluded shortly, and then the finalised report to be produced. But early learning from us sort of gives us an idea that one of the things that is an issue is about how the disclosure process is done and how that can be improved. And I think there's really, really good learning from that. And the Trust, having had a little bit of insight into this over the last number of months, have been looking at how we can improve that. We've actually been also talking with patients who have been impacted from this and taking the learning that they have and their suggestions and comments to try and improve the process. We have a new procedure that in Southern Trust that we're now more or less finalising now to see, can we get you to do that? That's about better communication with women to understand why they're coming for disclosure, to give them support before and after disclosure, because it is very, very harrowing to get that information. And also about who's present in the room. You don't really want to be met by a panel of about 10 people. You want people that you've met before. Usually it's the gynaecologist is the best guidance practice. So there's a number of learning from that. I think we can go forward. So you're right to say that the disclosure to date have not been as good as it could have been, absolutely, and I think we accept that very, very clearly. But I think there's real good learning we can put in place to improve that, and involving ladies who've been impacted by that and getting seen would have worked better for them, I think is really important too, and we have been doing that. The disclosure process we've come up with, I think we're also sharing that. We'll be sharing it with the other trusts. And our preliminary feedback actually is interested in this work we're doing to review the disclosure process across the UK, because I think there's a recognition across the UK this is a very challenging conversation to have with women, and I think they're interested to see what learning we have as well for this, because as I say, it has not been looked at in detail before. But I hope that answers the question, that we recognise as a problem, but I think there is really good learning that we've got developing for that going forward, and that will make disclosure is always going to be difficult, but hopefully it will be done in a better manner with better communication with women, and they get clear information given to them with appropriate support.
That doesn't help the people who've been through the current process, and those people have had a very, very harrowing time. What additional supports have you put in place for those women and their families?
Yes, so what we do is, and what's supposed to happen is that ladies will give a designated liaison officer who will support them through that process. So there's somebody that is not part of the disclosure process, but it's actually there specifically to support women, and they're specifically trained to provide that support and listen to questions. If there's any clarity, to make sure they can go back to the Trust's colleagues and get further clarity that's needed on various matters, but also to provide support for women in terms of psychological support, directing them to different pathways, whether it's psychological support from general practitioners, whatever. So it makes sure that women are not left on their own, and to make sure that they have other people with them when they hear news. So I think it's really important that carries forward, but liaison staff dedicated to a particular case is really important to have that, and as I know all trusts do that, and Southern Trust we certainly do that.
I see a lot of head shaking behind you, which would indicate that hasn't happened, and the distress it has caused is really almost unforgivable. and that really. Can I just ask a final question, Chair? So in terms of the Southern Trust, and many of us will have listened to the interviews that were given recently about the process whereby this came to light. So just 2 questions just to sort of clarify for me the process that the Trust took. When the consultant pathologist said, stop, there's a problem here, what happened and what was the timeline before action was taken by the Southern Trust?
So, the consultant in particular was reviewing the data, and he noticed issues with that. So he looked at the data and looked back a bit further, and then he took the precautionary step to take the various screeners off screening duties at that time. So and that was done by himself. So he liaised with the laboratory staff, and those staff ceased screening from that time. At that stage, then the member staff was then looking to try and raise those concerns up within the Trust, and this is in and around the time 2021-22. And we raised it with senior members of staff within the laboratory service. As I understand, what happened is that they then looked to try and investigate and look into that situation, and that was escalated up into the Trust senior management. Now, as I understand it, that process took too long, and it seems to have taken approximately 6 months for that to be escalated up to get further action to the senior team. The Trust got that information. There's a number of factors about that, and certainly we're speaking with people you've mentioned to understand it in much more detail. Those discussions are ongoing, and we're investigating that in detail to understand why that's happened, how that happened, and how that can be rectified going forward. But it does appear that the length of time it took to get those concerns escalated were longer than I would have liked. So if it was happening now today, I would like to hear things much quicker than that. But for those reasons, it seems that has got delayed. When that was seen, the information was seen at the senior table of the Trust by the Trust directors, it was acted on very quickly, and they instituted the Royal College of Pathologists review and so forth thereafter, and that's well known. But it does seem to be, you're quite right, there seemed to be too long a delay for that, and that's one of the things I think that the Trust apologises for, because that should have taken much quicker. But there's learning in that about how we do things further. Part of that's about Trust staff raising concerns and having them listened to as quickly as possible, knowing who to refer the concerns on to, and we're sort of making very clear to Trust staff that they should raise concerns directly with the line management, and if they can't, they come and speak to myself or other directors in the Trust, and we're very happy to hear that. There's also the whistleblowing process available, and again, we're very happy to hear any members of staff, and we do support staff in that, and discussions are ongoing with staff currently about this matter to make sure we get the full learning out of that from their experience. That's really important. But it was too long, absolutely.
So we're in 2025. This happened in 2021. And we're still in discussions with staff to get the learning out of it. That seems to me an incredibly long time to be discussing learning about something which should have been sort of pretty automatic. There's a problem here, we need to deal with it. Women's lives could be lost, we need to deal with it. I just think I'm incredulous about the length of time it takes to get action that really means that we are moving to do something very, very important. My final question is, my understanding is that when a woman is given or was given a diagnosis of cervical cancer, devastating diagnosis, they're not offered their cytology history, they have to ask for it. Is that correct? And why would that be the case?
Yeah. So what should happen is that every woman who is diagnosed with cervical cancer, and as you say, that is a devastating diagnosis, and there's a lot of information to take in. So at an appropriate time, the information, every single case of invasive cancer becomes part of the invasive cancer audit. But before that starts, that should be discussed with the woman at the point of diagnosis, so that she understands that we will in due course have a look at her screening history. If she had previously attended for screening, that her slides will be reviewed, and at that point, at the point of diagnosis, you should be given a leaflet which gives you some information. And the purpose of the leaflet is to give you information, but also because so you can take the information away, because there's an awful lot of information coming at you. So you should be told at the point of diagnosis, or as close to it as appropriate. What then the guidance then says is that the audit should be complete and shared with the woman. I think it's within 12 months, and whether or not the woman wants to have disclosure or not and to find out that's up to her. You know, it's something that she would discuss with the people looking after.
How is that person asked if they want disclosure?
So they should. So this should, as someone on the PHA, this is something that takes place in the trusts. But what the guidance says is that there should be a discussion with the person who is treating the lady. So quite often that's a gynaecologist who will say, well, the audit will take place. Do you wish to find out the results of the audit? How would you like to find out the results of the audit? But I know that having the work that the trust has done around some of the disclosure meetings that have happened have identified a lot of areas for learning, both in how the audit is discussed with women and how the information is disclosed. But it should take place with the treating team.
Okay, I'm not going to pursue it too much further at the minute, other than to say I have been given and had conversations with women who've had this diagnosis, and they've been given a leaflet and asked to tick a box. Did they want to know their cytology history? And it was only when they ticked the box that the trust arrived en masse to tell them what had happened. Unfortunately, one of those women is no longer with us. And I would like to think that the trusts, the PHA et al., will actually take this on board and understand how utterly devastating this is. To hear that your slide has been lost. You've had misread slides, some over 3 periods, 9 years. And only when cancer is diagnosed do you tick a box and ask, do you want to know? Thank you.
Okay, thanks, Dan. Nola?
Thank you. Thank you very much for coming today. I know we had another session at the actual trust premises. So a lot of my questions are questions that I asked then that we maybe didn't have the answers for back then. And I also just want to recognise that back then, whenever we first had the issues come to light, not the actual issues with screening, but the issues come to light, to the surface, that the people that need to answer the questions, aren't here. And that's why, the inquiry is the way to get the people to answer questions who were there. I think that's important to note because of the different faces that may actually sit at a table if it was an inquiry. I want to ask supplementary to Diane's question there, and that's that anyone who was diagnosed before 2019, what about those women in terms of their history?
So anyone who's diagnosed before 2019 who wishes to find out about their audit, they can. The best way for that to happen is for them to contact us in the PHA, and on the NI Direct website. There's a bit at the end of the cervical screening information where there's an email address, and if any woman diagnosed before 2019 feels that she hasn't had an audit discussed with her or she wants to find out more, if they contact that email, we will contact the relevant trust, and we thought that was a better way of doing it, to give them a single point of contact in PHA rather than them starting to chase into the trust and find out perhaps the person treating them is gone. So that's the best way to get it done, and we link them with the relevant trust.
Could I maybe just add to that, just to let you know, as part of the discussion we've had at the Oversight and Assurance Group, we asked that ethics discussions would be taken forward by PHA with the Regional Ethics Committee to inform what that approach would be. So the approach that has been agreed has been fully discussed with the Regional Ethics Committee, and it is this balance of harm. There is there's a piece about transparency and providing a route for people if they want information, but we're balancing that with potentially going back to people from some time ago where it might be re-traumatising. So we asked specifically that the PHA would have discussion with the Regional Ethics Committee, and they have had that to inform what the pathway looks like if people pre-2019 come forward.
What did they say? The Ethics Committee?
They advise that we make the information available
to women who wish to come forward, and which is what we've done.
And the reason why I think it's important just regarding that is because I am aware that one of the screeners was flagged with the Trust in 2019 regarding performance issues, that it was brought to my attention, but that no action was actually taken on that screener. Is this a true reflection of 2019 and performance then?
We'd ask you that from a trust perspective.
Thanks. I don't know the specific one you're talking about, but as I understand it, what happened is that the screener's performance was looked at and then had remedial action for that year. The feeling seems to be, and I think I said before at a committee the last time, is that they didn't look back into previous years to spot patterns of activity. So I think within the year, it was the performance, there was some remedial measures put in place, but what was not done the following year was to check, did it actually make a difference? We just looked at each year in isolation, and I think I described that to colleagues. I know some members changed, but the last time, and that's one of the things the learning we've got is to make sure you look across trends in more detail, and it's very obvious now, but for whatever reason it wasn't obvious then when these policies were designed.
And I think that is important because it could flag that there are women before 2019 that need to have their other audit done, and also then on data is very important. It's very important, but so also is conduct, and it has been brought to my attention as well that one of the issues is also around conduct and not just data performance. The same issue that was flagged in 2019, and then we move forward to 2022 in October, in which the whistleblower, who's already been on the news, he appeared in a UTV report, immediately took steps, 2021, to take 2 screeners off duty, and that was the right decision then to do. But I also am hearing discrepancies in when things were raised. So in terms of the 6 month, and I did ask the questions at the last committee, Stephen, regarding that 6 month delay. But there is a claim and a counterclaim, because there has been a lot said in public, that there was an actual meeting, an internal meeting, to deal with whistleblowing and grievances with the PHA to make them aware of the actual issue in February 2022. It's not known who was at that meeting from my perspective, but that it was raised then, and that quite possibly between February and July 2022, an associate medical director had already brought to the Trust's senior leadership the issue. And I assume that there would be paper trails of everything, given the amount of internal processes, grievances, anything that happens. And it just seemed the information that we're getting publicly at committee is being contradicted by information that we are being given in good faith in private as well. And I'm not sure how we can square that circle of who knew what when, and it brings me on to the question around that paper trail, and will there be a disclosure of when meetings were held, who raised what with who, and at what point the leadership team actually got involved.
Thanks very much for that. Like, my understanding is that various issues were raised, I think, as I mentioned earlier, by the consultant, and that was raised up to within the lab management. So what I understand then is that there was some looking at the data at that level, and then it was sort of escalated up and it bubbled up through the Trust through various levels, just as you described, but it didn't get to the senior director level of the Trust until in and around, I think it was June, July of that particular year. But prior to that, there was escalation within the Trust, but part of that was about, I suppose, internal scrutiny that colleagues were doing to look at the data, to understand it better, and to see what the issues were from their perspective. To my mind, that took far too long, because that should have been escalated up quicker, and I think I've said that, but that should have happened much more quickly. I would have preferred, if that wasn't the case, for me to learn about it whenever everybody else learns about that issue at one of the first steps, because that would I would expect now today. But that does seem to have taken far too long for that period, and whether people were over-checking data, looking at that, that seems to be part of the thing you're describing. So I recognise what you're saying, that there was a bit of time spent looking at stuff, but I think the problem is that wasn't escalated fully to the senior leadership of the Trust correctly, and as I said earlier.
And I only raised it because, I mean, the cervical screening scandal is not the only issue, that has risen in trusts right across Northern Ireland with regard to being open, transparent, and ensuring that there is that element of candour with what's going on. So it's just important that all of the I's are dotted, T's are crossed at every paper trail back to the 2019, and wonder whether whenever that screener was a yearly look at the just individual rather than trends. Was that escalated within the trust? Do we have all the paperwork for that? It is important because it just highlights when you should and get involved and who should be involved. I understand hopefully that will be reflected within the report and any learning from it. Another issue that I wanted to raise as well is the Kent and Canterbury inquiry, and whether there have been any examination of that and the issues that arose from that. My understanding is that during that screening there was 30 women afterwards up to 1919 and 1995. 30 women required a hysterectomy, 333 women had a misread slide, and they were told it was clear when it wasn't. There was a high risk, and 8 women died. And it took 6 years for their equivalent then to come out, admit and be open and transparent. I recognise it is better here with regards to actually coming to committee answering questions, but actually when you look at those stats compared to the population or the women that affected, it's lower than the stats here in Northern Ireland, and it was described at the time as one of the worst medical scandals that had arisen, and the figures that had come out of it, but yet we don't have an equivalent inquiry here, or and I'm not saying that individuals do this, but it is, the figures are almost diminished or dismissed because they're quite low, but actually when you compare it to population or to the 17,000 and then look at that inquiry, it's higher. The percentage here is higher with the amount of issues that have arisen. So
just to say a couple of things from the kind of overall perspective, and then Joanne might want to come in just in terms of the comparability piece. From a policy perspective, we haven't looked in detail at any reports coming out of the Kent and Canterbury, but we have had some information shared recently with us in relation to some of the data, and we would be happy to look at that and look at any recommendations or learning going forward. We certainly will. To the best of my knowledge, while there have been various assessments and looks backs and partial looks at parts of screening programmes, a full transparent report such has been published in terms of the review here has not been done by any other group or nation. So until I certainly would look at the detail of that inquiry, it's hard to know if we're comparing apples with apples, and that is part of the challenge here. But we will be very happy to look at anything anybody provides to us in terms of learning. Now, you've had some conversations, I know, with expert colleagues who work in other nations. Generally, I think their sense is that there hasn't been papers or reports, either peer-reviewed or published, which would describe a similar type review cohort that has been done in Northern Ireland. But you've had I haven't had the detailed discussion with them.
So just on the Kent and Canterbury inquiry, I haven't gone through it in detail in terms of the numbers for today to provide a comparison. I do know that one of the recommendations from the inquiry included the introduction of quality assurance for screening, that you have that sort of external thing. So that's been taken forward. One of the reports that we commissioned was that external review, the 2 external experts to look at what we found in the Southern Trust review, and as Lourdes has sort of hinted at, a big challenge was there's no comparator, there's nowhere else has done a look back of this size in cervical screening. So that report will be published in full, but that was, I guess, what you're asking is kind of what we were asking
in terms
then.
of years or numbers? Look back in terms of the years, or look back in terms of the numbers?
In terms of the numbers of slides that were actually physically reviewed. So because a bit like you were saying, okay, so we've done this review, how does it compare to similar reviews and exercises that have been done elsewhere? And the detail is in the report when it's published, but they weren't able to find anywhere, and they looked beyond the UK, a piece of work that was done of this scale, that to the detail that we've done it to. But again, that will be in the report, and I'm looking forward to the publication of the report so that we can be transparent. But
Yeah, I think I'm sure it'll be up at committee again in September. And I guess my last two questions I can give together is those two screeners that were removed in October 2021, were they removed just for cervical cancer screening? Are they screening in other areas, or were they screening in other areas? And also with regards to the regional, current regional screening, is that when did Belfast Trust seek accreditation, and versus when they actually started? Were they already doing it in 2023, and was accreditation then not sought until 2025? And just the reasoning behind that, if that is the case.
Maybe can I take the first one, Nuala? The screening for cervical cytology is a very specific skill for that, because of the nature of the slides, the material that's used to examine that, and it's not comparable with other types of screening that are done in other types of diseases. So in Southern Trust, those screeners were only doing cervical screening work, and they wouldn't be able to transfer to other stuff. So when they stopped cervical screening, they didn't transfer to other screening programs, looking at other slides or anything like that. That wasn't the case. They were doing other lab duties, which would be unrelated to that matter. So
if one of the issues was conduct, though, have we looked into that? As in, has there been an examination of whether the issue was
so the sort of duties that the technicians would do, they might be preparing slides or just technical preparation, taking slices of material, put them in chemicals on to fix them and so forth, and that sort of technical work that lab technicians do as well. And it's not a technical conduct, that's just a technical thing that's done as part of a broader team, whereas the screening work is much more subjective work that people have been doing on their own. The other stuff you do with other colleagues. So there's always colleagues working doing that. So the work they were doing is more general work they would have been doing. So it's not comparable related to that sort of thing, wouldn't be impacted. But you're quite right in terms of the cytology. That is very subjective, because you do it yourself on a room, in a darkened room, looking at slides. With other stuff, you're doing it in the general lab, working people doing the same work as you. So the stuff's interchangeable and much more. So it's a different type of work.
And then your other questions about the accreditation?
Yeah, if I probably start at the present and work back, it might be easier if that's okay with you. So we took on the regional lab in November 24. We already had our cytology UCAS accreditation. So we then applied for extension to the scope. Then, so we would have all our standards and our quality indicators in the lab. The lab, for UCAS to come and visit, they have to visit a live lab that's up and running to see that what we're saying is actually correct. So they come over for the visit, they look at it, they spend a period of time with us. So they came and visited us. They then asked for further information, and then on the basis of the visit, of coming to see the lab at that time, and the additional information that they requested, they then accredited us with the extension of scope in, I think it was June of this year, June this year. So does that answer your question for I'll go back to the other one. Do you anything you want to ask about that period?
No, I guess no. There might be some confusion as to the accreditation, and when you say they expanded the scope, so do you mean the screening work that they were doing before that for the Belfast area, for example? Is it just scope as in geographical scope? Like, what do you mean?
Maybe Joanne, you might be able to feel this is about the scope. This is cytology lab as it stands. Yeah. We then took on primary HPV in November, so we weren't doing that. So we then asked for the extension of scope to come in. So if they come back to us the next time, they will accredit us as a whole lab rather than in second lab. So we had to then bring them back on board, or we would bring them in to ensure that what we were saying, our quality assurance that we already had in the lab, was as we said, and that they were then okay to go down that, to sign us off at that stage. On the back of that, we actually brought in UCAS to look at all our accreditation in all our labs. We'd have that in a number of labs, how we could work better with them and how they could work better with us, and we could learn from each other. So we had a workshop in spring of this year with all our lab managers and UCAS to look to see how we could work better. So that's from November onwards. You mentioned again about in 23 when we didn't have the extension of scope at that time, and at that stage there were Joanne will keep me right because I wasn't in post at that stage, so hopefully I'll keep myself right. There was a backlog at that stage, and whilst we had all the quality indicators in house but not the extension of scope, there was look to see whether we could help with the equipment we had from pre-COVID as well, because there were a lot of analysers sitting there not doing any work. So we had the equipment and the staff at that stage, and we had our internal quality assessment there to do that. We worked through that with our team, and then we worked through that with PHA at the time to see whether we should go ahead and ensure that work was done and the validation took place. That's my understanding. Joanne, you were there.
And I think in 2023, Belfast Trust, for the reasons that Mario said, people were enthusiastic and they had the equipment and they wanted to do the HPV testing. But at that time, the HPV testing part of the programme was being commissioned from the Western and the Northern lab. So we didn't want Belfast to do it because it had been commissioned elsewhere. So that's primarily why they were stopped from doing it then, because we were already buying it from somewhere else.
Danny?
Thank you, Chair. We keep coming back to this, and every time we come back to it, I feel I have more and more questions. There's more and more gets uncovered, and then there's more questions just based on that. It's been said many, many times that this is an absolute scandal, and that the women affected and the families affected deserve full truth and transparency. And we should be striving towards that, and especially for those who are no longer here. You know, that absolutely needs to be said. We also need to build back confidence in the screening programme. It has been badly damaged. You know, women are seeing this on the news all the time, and I can only imagine what it must be like for those women. Given that, we'll have seen the interview, I think Diane referenced it there in her questions with the whistleblower. His name's in the public domain now, Dr. Michael McKenna. He was interviewed on UTV a couple of weeks ago. How do you feel he was treated as a whistleblower?
So, if I might answer that, we've been engaging with Dr. McKenna in detail about these matters, and those discussions remain ongoing. So I'm still meeting with Dr. McKenna because there's a lot of issues that he's raising, and to understand the depth and detail of that, and also understand his experience. So we're meeting with him, and those discussions are ongoing, and we are taking learning from that and working very cooperatively with Dr. McKenna. We welcome him coming forward, and I'm actually meeting him with another colleague to try and understand these matters in great detail. Because I think it's very important that we hear the experience that he has had, and part of the learning we have from that is to see if the measure we could put in place that would have made the concerns that he raised easier to raise, and do it in a normal process. So we're actively discussing those matters with him, as you'd expect, but I won't go into the detail of what those would be, but because they're still ongoing. But suffice to say that we do welcome his contribution to try and give us information that's available and to help us work through learning for that. I think it's really, really important. And on a more general point, we're really keen that if anybody has any concerns, that they feel free to raise them. And the door is open, so I'm very happy to take personal calls about these matters, and we will do that. But in fact, any member of the Trust staff will do that, but we're making it very clear to staff that they can do that and they'll be supported, because we want to make it safe.
I know you've said that previously in one of your submissions, and I'm glad to hear that, and would encourage any staff member, as I'm sure anybody would, to come forward. Do you feel he was supported well at the time?
I think, to my mind, I think he had support. I think could we have done better with more support? I think we could. One of the learning is that I think is that the feedback that I'm getting is that there could have been better support, and we could, and that's part of the learning that we're getting for this, how to make that better for people who raise concerns, and so that it's to make sure the concerns are raised, that the concerns are welcomed, so that you actually look for it with curiosity, say, well, what is that? And rather than question, that you look to see, well, what is that? Can I understand that better and work with colleagues to do that? Because at the end of the day, people come and they notice something, they want to raise it, make it safer. So I think that's the ethos I'm taking going forward, and certainly that's the way I'm approaching it. And the learning we're getting is to see how we can do that, Danny. So I hope that'll be helpful.
Absolutely, that's why he raised it. You know, he had noticed patterns, that long existing patterns of underperformance, that he was very, very concerned about. One of the things I'm unclear about is the lab inspection reports. So labs have to be inspected quite regularly with the PHA and quality assurance team. So were all the labs inspected regularly, and were those inspections up to date?
So just to clarify, just so we're answering the right question for you, are you talking about is your question really about the quality assurance piece every year, or is it about inspection? Because the likes of UCAS and other accreditors would be doing actual inspections of looking at the laboratory systems and processes. So your question you want to ask about?
Quality assurance, I think
Quality
it's
assurance.
an annual inspection. I think
It's an annual visit.
So it's not really an inspection as such.
Yeah.
So I think what UCAS do could probably be described as an inspection.
Mhm.
The quality assurance process, I think there's an annual data review, and then there is a process of a visit where the team actually go to the trust. Now that's not as frequently as annually. I can't remember the exact frequency of that, but there's certainly an annual data review where all the data is reviewed. And as far as I understand, they were happening. Now, there was I think the last kind of visit, and I think the visits were maybe, I don't want to get it wrong, but I think possibly 5 yearly, so the actual visits. I think the last visit to the Southern Trust Lab had been in 2019, so just before COVID. And then we had some disruption in COVID, but the annual data assessments or visits should have happened, not visits with sort of visits, virtual visits, sometimes a paper review. It's not, the team from PHA don't go in and inspect the laboratory as such.
They were all up to date though?
To the best of my knowledge, they were.
Okay. We see them?
So I will check with the team what we have available, certainly in terms of kind of the records of the various visits.
Oh, there's 4 labs, isn't there?
There were 4 labs at that
There were
time.
4 and there's 1 now?
Yeah.
Okay.
So sorry, not to interrupt, but just for clarity, much of what we are talking about is what was previously the case, as opposed to what will be the case.
I get that, I get that.
So there
I'm
were
just trying
4
to-
in Southern Stock. There were
No, I
3. Yeah, and now there'll be 1. And I think we can say, sorry.
Will be or is?
There is.
Is one.
And when we think about what the quality assurance would need to look like across that, that's the piece that PHA it will be using the NHS England report to help with designing the quality assurance framework and piece going forward.
Okay.
Because obviously it has to be different with just one laboratory provider.
From a couple of questions just around the Belfast lab. Now, did the Belfast Trust, the Belfast lab, review any slides during the review?
So the Belfast Trust Lab started to, or do you want to take this, do you?
You probably know better.
So the Belfast Trust Lab started to participate in the review of the Southern Trust Labs, I think in late February 2023. I get lost in the years, but late February 2023 they began to assist with the assessment of the slides.
They were fully accredited at the time?
At that stage, what had happened was UCAS had suspended their accreditation in October of 2023.
They weren't accredited.
So what had happened then, UCAS had identified some issues with the lab. The trust then did not participate in the slide review up until late February 2023. I'm totally mixed up with the slide, maybe 2024.
It's 2024.
24, late February 2024. And that was following a decision taken by the steering group for the cervical screening overall review, which Stephen and I co-chaired, and that was having taken into account all the UCAS recommendations, making sure that the trust had addressed any that were pertinent to cervical cytology, and there was a risk assessment done, and we made an assessment which we shared with the Department of Health, with the oversight group that Lourdes has referenced, to say Belfast Trust have addressed the main things from UCAS. The outstanding things are mainly recommendations, not mandatory, and they're not pertinent to the review. So our advice at that stage was that Belfast Trust then should start to contribute towards the review. And that was a carefully balanced decision, because you will remember how long it took to get through the 15,500 slides, and we were very conscious that women were waiting months and months and months, haven't received a letter. It was months and months and months. So we wanted to make sure that we got through the review, but only at the point whenever we could be sure that we could have confidence in the lab. So maybe Stephen will remember back to that decision making, but it was something. It was following a careful risk assessment.
Yes, no, I do recall that discussion, and there was a very careful, and the group we were leading was a cross-trust group looking at that, so we took views across all the trusts on that as well, and all the lab staff. I suppose there's a balance there. We were trying to increase the capacity. Belfast Trust is a large lab, and it allows to significantly improve the speed of the conduct of the cervical cytology review. But against that is about, as our understanding that I recall, is that we were informed that the measures that UCAS had query in Belfast had been addressed, but they hadn't done the formal inspection to re-accredit as such. So
It wasn't accredited at the time.
But they were waiting on that accreditation to come through. So the inspectors come through and then look through the records and look at it retrospectively. So, but that was a risk balance decision, and it seemed appropriate to do that.
And then Belfast was granted the one lab effectively after that. Can I ask just about the appointment of the Belfast Trust Lab as the one lab? Joanne had said in 2014 there was a recommendation to move to one lab in 2014. Was there ever a recommendation to move to two labs?
So there were 4 labs at one point in time in the programme. As part of the process to implement primary HPV, there were a lot of work streams and a lot of options that were considered. There was a laboratory work stream, and they had a big workshop at some point during this process. I've totally lost track of dates, but at some point during the process there was a big workshop. I think it was in February 2024-ish, about a year and a half ago. And there was a workshop which was made up of staff from all the labs, trade unions, a big group, and they scored, I think, 11 or 14 options, and they identified, I think, 4 viable options. The preferred option on that day with all the staff in the labs was a two-laboratory solution. Now that workshop then made recommendations to the overall Primary HPV Implementation Programme Board, which I chaired, but included among its membership Paul as Director of Commissioning, a pathology network representative, so an expert pathologist representing the network, an external person from a laboratory, a big cervical screening laboratory service in London, and some others as well. And it was a commissioning decision that was taken that we did not have the volume of work to support 2 laboratories, and I've referenced that earlier on. With our volumes at the minute, even as they are in one lab, are lower really than any other lab in the UK, and we know that the numbers will go down. So we took a decision as a project board, and it was a commissioning decision, that to make sure this laboratory was sustainable into the future, to make sure there was enough work being done and it was comparable in size to peers, that we couldn't sustain 2 laboratories in Northern Ireland.
Has there been a review into that decision?
So there was then an expression of interest process that happened. 3 trusts put forward expressions of interest. 1 trust was identified as a successful bidder. That was Belfast. One of the unsuccessful trusts did lodge an appeal, and there was then an appeal panel sat, and it upheld the decision to appoint Belfast as the preferred single laboratory.
It was good to hear. Obviously, the possibility of eliminating cervical cancer was fantastic to hear, and we've heard that a couple of times due to the programme and good screening. There is confidence has been rocked entirely, but it's good to hear that we have the new lab. Is the new lab up and functioning at the minute? Is it running?
Yes, it is.
It is running. In May, I'd heard in May that it wasn't, and that there were slides going to Gateshead. Is that correct?
No, not in May. When we took over the lab went up and running since November.
Okay.
And at that stage, there was a backlog with the other 2 trusts as we downturned services in the Western and Northern Trust coming in to start up the new lab with the equipment, etc. So we made a decision as a programme board for those who were waiting, rather than women waiting on slides longer than expected, because as we set up the lab, that we would then send some of our slides off to Gateshead. That would be our contingency, that if something happened to any labs in Northern Ireland, that we would have a contingency somewhere else. And at that stage, they're sent off. We haven't sent any slides off since that initial group at that time.
It's up and running at the minute.
Yes, absolutely.
Quality assurance at the minute. Who's doing the quality assurance inspections?
So
it can't be from another lab in Northern Ireland because there isn't one.
So there are standards within the labs, within the lab management system. So there are external quality assurance. These are just the tools that are used. There's interlab comparisons. We have the UCAS accreditations I talked about. We then we bring that up to trust assurance. We have also presented at the regional oversight cervical screening oversight assurance group, and then as Joanne alluded to earlier, the next stage is then to move to that independence of someone out of Northern Ireland to come in and assess. Then will be our final stage, and we're just waiting for
How often does that happen?
It hasn't happened.
So that has not yet happened, and the reason that not yet happened is we are waiting for advice from NHS England as to how we put the most robust quality assurance mechanism in place going forward. So remember, quality
The lab
assurance
hasn't been quality assured.
So the lab has been assessed and has been certified by UCAS. Plus, there were lots of other programs that Moira has referenced, the EQA
Interlab.
thing, the interlab stuff, the stuff within the trust. The PHA, quality assurance, looking at the data, which happens, as you know, happens annually. That has not yet happened. The lab hasn't actually been up and running for a full year yet, but that will happen by the time it is. And we have recommendations from NHS England as to how we put something robust in place. And they make a number of observations and comments on some of the arrangements we had in the past. So we want to make sure that what we put in place for the lab going forward is as robust, and we'll be taking their recommendations on that and implementing it.
And we really look forward to being involved in that. I think that's really important to us as a lab service and to our women who are getting those services. Absolutely.
It's about rebuilding that confidence,
Yes,
and just that we have one lab now,
Yeah.
you know, and that the future is a lot safer and more effective for those women. Dr. McKenna, the whistleblower I mentioned at the start, he said in his interview that he has concerns that oversight and quality assurance of the programme at the minute have not significantly changed. How do you respond to that?
So I think that the NHS England review definitely identifies areas for us to improve. It does note that our processes have significantly improved in the last few years, so I think that's a welcome thing. I think we would accept that there are things that we want to further improve. I've referenced some of the things around how specific we are, around some of our definitions. I think there are also things around how we work with trusts to make sure that there's an understanding that certain things are not optional, that they must be done and they must be done in this way. So I think that the report recognises there have been improvements. I think there will be further improvements, and as Maura has said, there are a range of other external process accesses, including but not limited to UCAS as well, who are in the lab. So
The whistleblower that started this whole thing doesn't have confidence in the system, that there has been enough change at the minute. That's pretty damning, I think. But I hope that,
I might comment just on the confidence issue. It wouldn't be appropriate for me to pick up specifically on the whistleblowing piece, but on the confidence issue, it is really important that confidence in this programme is maintained. It's hugely important. I mean, all of our focus in terms of serving what has happened already, but in serving our sisters, daughters, friends going forward, is that we do all the work we can to eliminate as much as we can cervical cancer. I think, as I've said in my opening words, and Minister has said, you know, we are deeply sorry for what's happened, and we really regret what has happened, and we've acknowledged the huge impact it has had on individuals. We keep a close eye through the PHA on participation in the programme. To reference your words about potentially eliminating cervical cancer, the WHO, the World Health Organization, would say you need to keep your vaccination rates high, up 80-90%, and you need to keep participation in the cervical screening programme high, at least at 70%. When we look at the data for 23-24 and the previous year, we don't see a drop-off in participation in the programme overall at the regional level, which is good. And the participation is in and around 70% of eligible people, with some variation, some minor variation across the regions. So the participation appears to be holding, which is really, really important. And what's also important is when we look at it by trust area, in the southern area, the participation has gone up slightly in the last year by a couple of percentage points. So that's encouraging. We'll be keeping a close eye on it. That is not to say that what has happened hasn't had an impact on people, because we do recognise that. But when I'm looking at it from a population level, I don't see a worrying drop-off at the moment, which is really important.
Good. And that's to be welcomed, absolutely.
Yes, and we will continue to focus on that. What has also been important is, and members here have given us support in terms of having discussions with other groups, lots of industry and other groups, about highlighting the importance of getting children vaccinated in school and of participating in the programme. We know from the Omnibus survey that about 20% of people, when they're asked, say that they either have never or are unlikely to participate in screening. We have asked with the PHA to begin some work now to try and reach people who have never participated, because that 20% of people who haven't ever participated are a really important group to also have come on board.
I understand the results from Scotland are very, very encouraging about young women who have come through the HPV?
Yes. Yes.
And just in terms of our HPV uptake rates, again, I'm looking at last year's figures, so they're done in school. So this is girls in year 10. 77% of girls in year 10 have had their HPV vaccine by the time they get to the end of year 10, and for boys it's 72%. So obviously we would like to get that up higher, but it's a really, really important vaccine. So with the combined efforts of keeping our screening coverage as high as possible, getting young girls and boys vaccinated, and really reaching into people who maybe don't participate in screening or vaccine, we hope to really reduce our rates.
We would always encourage people to get vaccination.
Thank you. That's really helpful.
Thanks. Al?
Yes, thanks, Chair. I'm going to be brief. I've just one question to ask, which I'll get to. The feelings involved here happened over a considerable period of time, and we've heard this afternoon about the active steps that have been taken to avoid the identity of the individual screeners becoming known. Now, I appreciate and I respect the panel that is sitting here today in front of us, dealing with the hard questions with perhaps no direct involvement in the scandal. So my question is, where does the buck stop in the Southern Health Trust in regards to this life and death scandal?
If I might take that, yeah. So one of the things we have identified is that there's certainly a large number of system issues in this, and there was issues around governance that weren't properly dealt with, and we've sort of talked about some of those earlier this afternoon. There's issues about the quality assurance and oversight. We've talked about some of those as well, how we can strengthen that as well. So, and the thing that strikes me looking at this, so, as you sort of suggest, fresh, is that the system has changed and modified, improved over the years. So the system in place back when this all started in 2008 is quite different from what it is now today. And most strikingly, because cytology is now done entirely in one lab, and it changes matters, and hopefully it'll improve quality further. It's quite easy, and I know it's a sort of a thing to say, to look back and see things differently, but when you look again back at the paperwork through the years, and have spent a bit of time learning about and doing this, is that you see how the system has improved, and there's been various improvements come through because of learning that's come through to change the system. So the framework in Northern Ireland, and Joanne probably mentioned this, has changed a number of times as learning has come through. Part of that's because of learning through the audit of invasive cancer, some external reviews have been learning, as I understand it, from the bigger systems in England, Wales and Scotland, and they've allowed us to improve the learning as well. But what is clear is that the systems were quite different back, as they started, and that's I suppose that's improvement of healthcare as we go through in this particular thing. You see that quite clearly. That's not to say that there's some, you need to make sure you follow the processes and the procedures, and I think that's maybe what you're hinting at, is to make sure that you do that, and part of that's about staff training and awareness of the importance of that, being awareness of governance, and certainly we're putting efforts into making sure that staff learn about the importance of governance, raising concerns, and then using that to improve the system going forward. So that's the work we're doing now to make sure that some of that wouldn't have been as obvious a number of years back, but that's a journey we're going through in healthcare right across the UK, but we are focused on it in Northern Ireland and particularly in Southern Trust.
We're unlikely to see anybody then ultimately taking responsibility for this.
Well, I suppose it's also, I think you had hinted at in your start of the question, is that some of the staff have changed as well, so some of those things change as well. So staff changed and change roles, retire and so forth as well. So there's an element of that in it as well. But a lot of it's about the system change as well, and it's actually quite hard to pin down to an individual the system change and how that's done. But I know it's difficult, but that's...
Maybe just to add to that, just to reference what I said opening, Minister has consistently said that he wants to understand what happened, why it happened, where the accountabilities lie, and what the actions are that need to remediate to make sure it won't happen again. So we are 2/3 of the way through getting all the various reviews and reports done, but Minister has then charged us as officials at setting out and seeing if all the work done clarifies exactly those questions for him, and he's not going to make any determination about what else is needed until he sees that.
I accept that's the most important thing, that this never happens again.
Absolutely.
Okay, you finished?
Yes, thanks,
Okay,
Chair.
thanks.
Thank you. Thank you.
Robin?
Just a very quick question, Chair, very conscious of the time, and it has been given a good airing today. just on the whistleblower, a man of integrity. There has been commentary, public commentary, with regards to how he feels he was professionally undermined. Not my words, his words. Do you accept that?
So I'm going to ask maybe Stephen to comment, and then maybe Joanne might wish to comment towards the end.
So we've been engaging with Dr. McKenna, and I don't want to go into the detail of that, but what I will say is that Dr. McKenna continues to practice as a consultant histopathologist in Southern Trust and works in the regional laboratory as well. We have full confidence in his ability. He continues to practice fully at the present time. There have been issues about transitioning into the new service, but we have full confidence in his abilities, and he's fully supported. And when I'm in discussions with him, we're making sure that that's the case.
Does anyone apologise to him?
Sorry?
Anyone apologise to him?
Well, as I said, I'm in discussions with him at the present time, and that's still ongoing. So it's clear, and we firmly recognise that things could be better. And I said that a few moments ago, that there could be better support for people who raise concerns. And so we are discussing that with him and taking on board his listening, and we're together working out solutions for that. So
you do recognise that had it not been for that man and the integrity of that man, that we could have other empty chairs.
No, absolutely. And as I said, we welcome him, and that's why I've been really keen to engage with him. Absolutely. We do. I do personally thank him for coming forward and engaging with us. I think it's really important. You're right to raise that point. It's really important.
Very, very quickly, Linda.
Mine is a point, not a question. It's just to reiterate, if we can do more work around making sure and this is not exclusive to cervical screening, in all screening processes, to ensure that people understand the difference between screening and when you're symptomatic, because I do still think that there are people who think I have had a smear test, that smear test. If you are symptomatic, you need to go to your GP, and your GP needs to know, not to think you've had so probably you're okay. That is not the approach to take, and I just think there needs to be a wee bit more work around that, because I've had recent experience of individuals who've been told you're probably okay because you've had a breast exam or you've had your smear, and that's not the case. If you're symptomatic, you should be treated as though that never happened.
That's a really important reflection, first of all, and was part of what I was trying to say in my opening commentary, because even though patients will experience them all as the same service, whether it's screening or symptomatic, it is quite complicated behind, because they're the way we look at them and plan them and manage them are actually two totally different things. We look at them quite differently. It is a different thing calling somebody forward for screening who doesn't have any symptoms, or you would hope no illness, versus somebody who comes forward with a symptom, any symptom. That they're totally different things to plan and manage, and they're totally different things for the patients. So I think those reflections are they're really helpful overall for what we're trying to do, but they're equally and probably more important for people who have symptoms who should come forward. Now, PHA, I know it has done some work on written material and written information around cancer and cancer symptoms and coming forward. You probably see all this in your own community pharmacists. I see it every weekend when I'm in getting things in the pharmacy. But work is ongoing and is just starting about having ladies involved in actual planning and working the screening programme to get those kinds of messages much more clear.
Okay, and equally briefly, Diane.
Thank you, Chair. Just a reflection on Dr. McKenna. I think that he has been one of the most courageous doctors to actually come forward and put himself out there. I'd like you, Stephen, just to clarify, when Dr. McKenna became a whistleblower and said, "This thing's wrong here, this must stop," what happened to him professionally? And what do you do? What's the trust intending to do generally in terms of making sure that whistleblowers can come forward and are protected and not penalised? And that's number one. And really just then maybe to Joanne, just clarify for me, during the time that the Belfast Trust labs were not accredited, when they lost their accreditation in 2023, I think it was, did they still continue to do cytology screening? And are you satisfied with that?
Will we do the laboratory piece first? Cytology piece first, if that works?
So again, whenever they lost their UCAS accreditation, there was a risk assessment done as to whether or not we should stop screening in Belfast, who at that stage I think were doing 40% of the cytology in Northern Ireland, or whether or else send the cytology to other laboratories. So what happened was there was a very detailed risk assessment done by ourselves with SPPG, and we met with the trust, and we, having completed that, looked at the type of recommendations that UCAS had made. A decision was taken to continue Belfast participation in the screening programme and doing cytology in spite of that, but some additional measures were put in place around some of the recommendations. So more frequent reporting around their sensitivities and their actions in relation to that. And that risk assessment then was brought to the Department of Health and to the oversight group that Lurda has mentioned to make sure that our assessment that the continuation was in the better interest of women.
You were also doing the review at that time?
So they didn't. So we didn't. So they hadn't started the review at that time.
Mm-hmm.
So they didn't start. We didn't allow them to start the review until they had dealt with the issues that UCAS had raised. But as I say, that there was a risk assessment done and some additional mitigations put in place, and that was something that we did with colleagues in SPPG, with the trust, and then providing some assurance through the oversight group to the department of the measures and steps that have been taken.
Dan, second point.
The second point is
I think it was about the experience of the whistleblower. One of the things that I've sort of been exploring in detail is to understand the experience and the impact on, in this case, obviously Dr. McKenna, and it's really important to listen to that, and I've been listening closely just to understand what the impact that was, and how whenever you're dealing with various issues, to make sure you remember to keep on top of all the aspects of the practitioner and so forth. And so we're taking his feedback directly on that, and putting part of the learning we've got is to try and make sure that we really fully recognise that routinely going forward. So I think there was some issues in the time before we had a discussion with him where there might have been some impact due to external factors, not necessarily as part of the whistleblowing as such, but one of the things I suppose for that is the learning how do we make sure we support colleagues through that. So there was support given. Was it sufficient? Possibly not, because Dr. McKenna has indicated that it had some impact on him, but the outworkings of it all is that has been very successful for him going forward. And as I said, he's fully supported by the trust and contributes well to the system going forward at present. So, but the key thing is to get the learning from that, and we're engaging with him to understand what those matters will be and what make a difference going forward.
Okay, folks, we'll draw it to a conclusion. I mean, that was such an important session, which is why I allowed it to be extended by an hour, but I think it was important to allow members the opportunity to ask the questions that they wanted to ask, and also to point out that we will be expecting to see you back, or certainly some of you back, in order to get the other reports published. So this is not the end of the questioning, I suppose. So I do thank you for the time that you've given us today.
Thank you very much, Chair.
Thank you. Thank you. Thank you.
Okay, members, just moving on to item number 8. So, written briefing on winter preparedness. Can I refer members to the
Can I just come in just on the back of that?
Okay, sorry, I should have said, I should have allowed a bit of time. So just on the back of that, then we'll obviously write to the department to seek another briefing once those reports are published. That's one thing. Danny, you wanted to come in on that? Can I just say, in case members rush off, don't know if you were packing to go there, Alan, or not, you were.
We're at 4:45.
Okay, well, can I suggest that we maybe go into private session just for 5 minutes?
Yep.
Because I have something I wanted to say to members before they go.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29, 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 Sound.
Number 8, written briefing on winter preparedness. Refer members to the written briefing at page 19 of table papers. Any comments? We are getting an oral briefing when we come back, so. And written briefing on hospital car parking charges, written briefings at page 249. I'm going to ask the same, that we get an oral briefing, because it's a big issue in terms of hospitals being prepared.
Need to ask questions.
So I think we should give an oral briefing.
I asked that it's not just the general issue of the legislation and the implementation of it. I have had a lot of contact from Ulster Hospital staff and workers, Royal staff and workers, where their car parking passes have been removed and they have no place to park. Remember, some of these nurses are doing 12-hour shifts. They're starting very early in the morning, they're finishing late at night, and I mean, they're not going to get public transport if you live a long way out of Belfast to be able to do that, and then get off at Central Station and then walk to the Royal. So I do think we need to explore what's happening in those individual areas, because now the two main ones that I've had representation about are the Ulster and the Royal.
So there's the issue of the legislation and implementing the legislation. My information is, because I think we were told one of our written briefings, that aside from that, the individual trusts and hospitals would be engaging with local MLAs, because there will be specific issues in some hospitals, car parking, that might be different elsewhere. So one of the things we should be encouraging is trusts to be reaching out to local MLAs to discuss the specific things, but the generic issues and the local things, then we definitely need to ask questions on. Okay, and then similarly, written briefing on prevention of violence and aggression towards staff. So that's at page 29 of table papers. I mean, we keep getting these. I keep taking deep breaths every time I read them. The figures are absolutely shocking. And so I think at some point we do need to get somebody from the department to talk about how they're going to reduce that and the strategies that they have in place, because like, there's supposed to be zero tolerance against our public sector workers, particularly our healthcare workers, and I mean those figures are absolutely shocking. Danny?
Thank you, Chair. The breathtaking, as you say, to think that healthcare workers are being assaulted on, seems to be a daily basis. We're talking 2 months there, and there's 2,000? So 2,000 attacks in 2 months is absolutely shocking. I've experienced this myself, and I know colleagues have as well, and I know careers can be damaged by this. and this can lead to people actually leaving careers that they really wanted to be involved in. So it is very, very damaging to the person, and as you say, zero tolerance should be what we're looking for. Could we ask for a bit more information just to see trends on this? Do we see where the numbers are going up, going down, just across those particular trusts? But 2,000 incidents in 2 months is absolutely unacceptable.
And one of the things this committee can do reasonably well is shine a spotlight on something, and I think that's something that we could definitely do moving forward. Yes, no.
I wonder if anyone knows whether they've implemented in the Northern Trust in Antrim Area Hospital, I believe it was, the body-worn footage.
Trust, yeah.
Have they implemented it already? If they have, if there's any, like, early updates, but if they've not, obviously, no question.
Okay, we can ask that question, can we?
I think we've heard that there's a pilot.
Pilot,
in
It is a
Antrim.
pilot, yeah, but I don't know if it's started yet.
I think it's just an A&E, possibly.
Yeah.
Okay, yes.
It's just a very quick point on that. I think we need to get an understanding of, because there's a difference in terms of the aggression towards staff, and if it's where somebody is in severe mental health distress, we need to get an understanding of that. That doesn't excuse it. But if you can't help it, and people with neurodiverse issues and learning disabilities, we need to get an understanding of that, because we need to be careful not to tip things.
And that was the explanation.
Yeah, they say that. Yeah.
And is it the South and Western Trust?
Yeah.
That so. But
doesn't
that's
excuse it, don't get me wrong.
But I think that's why we need to have a conversation rather than reading from a written briefing, just to ask some of these questions. Anyway, moving on, item number 11, SR by the Pharmaceutical Society. So can I refer members to papers at tab 7, the SL5, the SRs at page 255, and an explanatory memorandums at 261. So the committee received a briefing from the Pharmaceutical Society on the 19th of June, was content with the merits of the policy. The examiner of statutory rules hasn't yet reported on the technical aspects of the SR. Therefore, today members will be agreeing the SR subject to the examiner's report. Are members content in that scenario?
Yep.
Okay, so formally I have to ask that the Committee for Health has considered SR 2025/117, the Pharmaceutical Society of NI General Amendment Regulations NI 2025, and subject to the Examiner of Statutory Rules report, has no objection to the rule. Content?
Yes.
Item number 12, Adult Protection Bill. So there was a draft motion to extend, and that's at page 34 of our table papers. Are members content with the motion to extend our period of consultation? Yep, thank you. Correspondence, item number 13. So correspondence, we received correspondence from the Community Pharmacy NI, that's at page 588. So, that's asking questions of the Minister, and it's also asking questions of ourselves to support the Community Pharmacy NI, and I would suggest that we do. I'm just trying to bring up exactly what they had said. So, we would ask that the Health Committee supports CPNI request that the Health Minister meets with them and agrees for a negotiation process to be put in place. I would support that. Danny?
Chair, as Chair of the All-Party Group on Community Pharmacy, I'd have to declare an interest, but certainly I would absolutely support that as well.
Okay, happy with that? Okay, thank you. The correspondent index is at page 267 of the main pack and page 35 of the table pack. Are members content with the suggested actions in the indexes?
Oh, I've one. I can find it.
You're going to raise something, Diane?
Yes, 297. The Belfast Trust one on the fire safety briefing. Could we write and ask when those issues were first raised? It's sort of in the paper or in the responses if this was just a wee visit that happened on the 11th of June. I think it was over a much, much, much longer period of time and wasn't addressed, which was why the threat of enforcement action.
Yep.
just for clarity, just so that they know we're always seeking clarity.
Yep. Happy. Linda?
Just in relation to the parents for PEGs, and yes, I agree with forwarding it to the parents, but actually linking it in probably with the next piece of correspondence around paediatric waiting lists. I would like at some point we've talked about children's services being a priority anyway, but I would like at some point to get a briefing, to be given an opportunity to ask the Trust about, and this is such a broad, I know it's such a broad sweep, but it seems to be that children's services right across the piece, surgery, waiting lists, counselling, mental health support, everything to do with children is just non-existent. As far as I can see, it is literally non-existent. Our children are not getting anything like the services they require or deserve.
Okay.
It's the biggest issue that's coming to me at the minute.
Right, okay. So you're suggesting a briefing?
Yeah, and I mean, I'll speak to Keith about maybe narrowing that down, but that's very broad, I know. So maybe trying to take it in chunks, but I definitely would want to hone in on some of the stuff around children.
It's one of our priorities. We agreed at the
It is, yeah.
away day. And so when we're finished with palliative care, do we assess then where we go from them with the other priorities?
Yep, well then we need to just look at it.
We will certainly look to have a discussion in September around the programme from September through to June again.
So I'm happy to then have that as part of that discussion rather than, you know, because sometimes you suggest things well-meaning and it gets lost in the middle of stuff, or you're not really doing things in the way, I suppose. I've lost my words,
yeah.
but doing it in the most effective way. So let's throw it in as part of that.
And we'll have a better sense of where we're at in September.
Yes, absolutely.
I mean, there's lots of things we might want to do, but
yeah,
whether we have time, legislation, and like we'll be in the flux of winter pressures once we come back to, no doubt. But anyway, it's definitely something we should be looking at. Just members, to let you know, the committee will continue to receive correspondence over the summer period. If we're content, what we'll do is we'll get them in 2 batches, so sort of one each month of the summer rather than get them when they come in. Everybody's happy enough with that?
Yeah.
And obviously if there's anything urgent, that will be treated differently.
Absolutely. If we get some of the responses even from today, so it is, we'll make sure they get out to members.
Okay, forward work programme, it's at page 599. Everybody content to note the briefings for after recess are set out in the forward work programme, and then we'll probably change them in September. Okay, item 15, any other business? I think we've discussed any other business throughout the committee there today. Date, time and place of next meeting. It gives me good pleasure to say that the next formal committee meeting is Thursday 11th September here, room 29 at 2 p.m. But just also to alert you, we have the committee session on Thursday the 4th September and that'll be issued to members near the time. And then the last thing for me to do is just to wish everybody a happy summer recess, get well rested and refreshed for the busy period when we come back.
Committee Room 29, Sound.